Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Selamat pagi, Profesor, Dokter, Senior, dan sejawat semua di seluruh Indonesia. Perkenalkan, saya Dr. Yoga Fatori yang akan menjadi MC pada acara hari ini. Pada sesi ini, kita akan mulai dengan How to Session yang akan dimoderatori oleh Dr. Haji Bambang Triyanto, spesialis obstetrik ginekologi konsultan. Sebelumnya, perkenankan saya untuk membacakan CV singkat beliau. Dr. Bambang Triyanto menyelesaikan studi sebagai dokter spesialis obstetri dan ginekologi di Fakultas Kedokteran Universitas Airlangga. Dilanjutkan dengan menyelesaikan studi sebagai konsultan di Fakultas Kedokteran Universitas Indonesia. Dan saat ini beliau bekerja sebagai staf di Divisi Obstetri Sosial, Departemen Obstetri dan Ginekologi, Fakultas Kedokteran Airlangga. Kepada Dr. Bambang Triyanto, waktu dan tempat kami persilakan. Dokter.
Ya, jadi pada sesi ini kita akan ada 3 pembicara yang masing-masing bertolak dari keadaan pandemi membahas layanan kesehatan ibu dan anak, berikut dengan kualitasnya maupun referralnya. Yang kedua, bagaimana menjaga kualitas saat pelayanan maupun referral system maupun setelah keluar dari rumah sakit dalam keadaan pandemi. Yang ketiga, etik. Apakah mereka yang tidak berdaya ini dalam keadaan emergency etik ditinggalkan, nanti beliau Prof. Jambur. Untuk yang pertama, kami persilahkan kepada Dr. Okpi dan akan saya bacakan kurikulum beliau. Tahun 2017 Master Public Health dari UGM, 2006 PhD FKM UI, 2006 Obstetric Konsultan FKUI RSCM, 95 spesialis di RSCM. Saat ini menduduki beliau banyak kedudukannya, terutama dengan di POGI dan Kementerian Kesehatan. Di Pogja Pagi di POGI sebagai Ketua Komite Akademik Oksi, Wakil Dekan di FKUI, kemudian Staf Sosial Obstetrik, dan juga Vice President Indonesian College of Obstetrics and Gynecology. Kami persilahkan waktu 20 menit, dan pertanyaan nanti dikumpulkan para pendengar untuk dibahas pada 20 menit yang terakhir. Kami persilahkan, terapi.
Baik, terima kasih pada Dr. Bambang, para peserta semuanya. Assalamualaikum warahmatullahi wabarakatuh. Saya izin share screen. Pagi ini saya akan menyampaikan materi tentang peran POGI, seluruh anggota POGI dalam program peningkatan kompetensi dokter untuk pelayanan kesehatan ibu. Nah, jadi para sejawat sekalian, terima kasih Dr. Bambang sudah mengenalkan saya. Ini sahabat saya sejak lama sekali Dr. Bambang ya. Kematian ibu di Indonesia masih tetap menjadi masalah. Pak Jokowi sendiri sebagai Presiden Indonesia mengingatkan bahwa kematian ibu dan stunting masih masuk dalam 2 program prioritas untuk diturunkan atau diperbaiki di Indonesia. Nah, proyeksi angka kematian ibu di tahun 2019 memang diharapkan sebetulnya tahun 2020 kita akan turun. Tapi sekali lagi tidak mungkin penurunan angka kematian ibu sesuai target bila tidak ada program-program yang bersifat ekstra atau lebih dari yang program-program biasa. Sudah banyak program yang baik, tapi kita harus usaha ekstra untuk melihat apa yang menyebabkan kematian ibu. Sayang memang kita tidak diuntungkan dengan pandemi ini. Bisa diramalkan bahwa selama tahun pandemi ini, tahun 2020 ini, maka kematian ibu tampaknya tidak mungkin turun. Tapi kita tidak akan putus asa untuk tetap melanjutkan program-program, karena kita tahu memang pandemi ini adalah sesuatu yang luar biasa. Pada tahun 2019 kematian ibu yang tercatat di Indonesia itu sekitar 4.200, 4.197, tapi baru sampai pertengahan tahun saja, maka 2020 ini kita sudah mencatatkan 2.500-an, sehingga kita menduga bahwa angka kematian ibu bisa mencapai 5.000 pada tahun ini. Tapi baiklah, itu adalah hal yang khusus karena pandemi. Namun demikian, kita melihat bahwa penyebab kematian ibu dari data-data yang lalu masih disebabkan oleh 3 utama, yaitu perdarahan, hipertensi atau preeklamsi, dan yang sisanya adalah penyakit-penyakit yang memang sudah diderita ibu sebelum dia hamil dan memburuk pada saat kehamilannya. Nah, karena itulah di sini kita lihat bahwa dari analisis kematian ibu di Indonesia, bahwa sebagian besar ternyata kematian ibu didasari pada kondisi kesehatan ibu sebelum hamil. Kalau perdarahan mungkin karena ibunya sebelumnya sudah anemia, hipertensi karena ibu sebelumnya sudah punya faktor risiko yang tidak diidentifikasi secara dini sebelum atau pada awal kehamilan. Nah, untuk itu perlu memang kompetensi seorang dokter di FKTP dalam melakukan pemeriksaan kesehatan ibu sebelum atau sedini mungkin pada awal kehamilan dan menata laksana masalah medis atau obstetri yang ditemukan selama masa kehamilan. Tentunya tidak bisa sendirian, tapi berkolaborasi dengan dokter spesialis di fasilitas kesehatan rujukan. Kenapa? Karena memang tidak mudah memilah atau memisahkan temuan-temuan secara anamnesis, pemeriksaan fisik maupun temuan dari pemeriksaan penunjang yang mengidentifikasi bahwa ibu ini menderita masalah medis atau obstetri, dan ibu yang sebagiannya lagi adalah ibu-ibu yang betul-betul normal, karena hanya ibu yang betul-betul normal yang boleh dilepaskan untuk tetap melakukan antenatal care sepanjang masa kehamilan di FKTP, karena ibu ini awalnya sudah normal. Tapi kalau awalnya sudah ada masalah medis, maka perlu kompetensi seorang dokter untuk melakukan analisis. Apakah si ibu selanjutnya boleh tata laksana asuhan antenatalnya tetap di layanan primer atau sudah harus berkolaborasi dengan layanan kesehatan rujukan. Apalagi tentang persalinannya. Seorang dokter yang bisa melihat adanya masalah medis dan obstetri, yang bisa memberikan rekomendasi untuk rencana persalinan. Nah, selama ini memang ini belum dilakukan, tapi kita saat ini bisa melihat bahwa untuk menurunkan angka kematian ibu, usaha kita memang harus sangat kuat. Keluarga berencana adalah pilar untuk menurunkan angka kematian ibu. Dan keluarga berencana bukan sekadar menawarkan alat kontrasepsi, tapi memberikan pemahaman pada keluarga pentingnya merencanakan keluarga dengan baik dan tidak diperkenankan untuk seorang ibu yang masih dalam kondisi kelainan medis atau punya risiko medis untuk hamil sebelum kondisi medis tersebut ditangani dengan baik. Nah, pemeriksaan kehamilan juga perlu kolaborasi, kita lihat, antara dokter dan tenaga yang lain. Kenapa? Karena selama masa kehamilan pun seidentifikasi ini harus dilakukan sedini mungkin. Dan itu hanya bisa dilakukan oleh dokter. Pada masa kehamilan muncul masalah, hanya dokter yang bisa melakukan analisis masalah. Karena memang seorang dokter sebagai seorang physicians diajarkan untuk melakukan analisis masalah. Bukan hanya melakukan tata laksana sesuai dengan standar, tapi menemukan masalah dan melakukan analisis masalah. Begitu juga rencana persalinan harus dilakukan perencanaan sedini mungkin tergantung kondisi ibu. Sehingga tidak seluruhnya ibu dirujuk sudah dalam kondisi gawat darurat. Nah, ini akan membebani rumah sakit maupun layanan primer apabila seorang ibu baru teridentifikasi bermasalah di saat-saat persalinan dan tata laksananya harus selalu dilakukan emergency. Nah, kita lihat fasilitas pelayanan kesehatan primer merupakan dasar dari safe motherhood dan kekuatannya ada pada seorang dokter. Nah, untuk ini POGI sudah membuat PNPK untuk prakonsepsi, yaitu untuk menata laksana calon ibu sebelum terjadinya kehamilan. Kemudian PNPK rujukan masa hamil bila terjadi masalah saat hamil dan rujukan pada saat persalinan. PNPK ini memang diperuntukkan oleh untuk tenaga medis, yaitu tenaga dokter. Baik yang prakonsepsi, kita lihat permasalahan yang ada adalah usia remaja yang menikah di Indonesia ini masih tinggi, komplikasi kehamilan masih tinggi, ada infeksi, ada risiko cacat karena kondisi ibunya, ada perempuan-perempuan dengan penyakit menular dan tidak menular, dan dengan kondisi status gizi yang tidak baik. baik KEK maupun obesitas. Nah, ini tugas berat dari seorang dokter dan POGI sudah membuatkan PNPK-nya sehingga kita berharap nanti pelayanan kesehatan pada masa sebelum hamil bisa dilakukan oleh dokter. Tidak hanya tenaga paramedis, tapi harus dilakukan oleh dokter sedini mungkin pada awal kehamilan atau sebelum kehamilan. Dan fasilitas kesehatan rujukan juga bisa mempunyai tenaga-tenaga dokter yang membantu para dokter spesialis dan kolaborasi antara layanan primer dengan layanan rujukan yang baiklah yang bisa mencegah ibu ini dari mengalami kematian pada saat hamil atau mendapatkan risiko pada janinnya. Banyak hal yang dalam ruang lingkup asuhan prakonsepsi seperti status nutrisi, vaksinasi, mengevaluasi kondisi genetik dan termasuk penyakit-penyakit genetik seperti yang banyak di Indonesia adalah thalassemia, kemudian penyakit-penyakit seperti lupus erythematosus. Ini adalah kondisi-kondisi yang harus teridentifikasi pada awal. Begitu juga penyakit tidak menular. Penyakit tidak menular ini adalah kondisi yang banyak terkait dengan kondisi metabolik seperti diabetes mellitus maupun hipertensi. Hamil dini, yang hamil tidak diinginkan, penyakit menular seksual, HIV, kesehatan mental, kondisi fertilitas, kemudian kekerasan dalam rumah tangga, kesehatan masyarakat. Ini adalah hal-hal dan juga mereka-mereka yang menggunakan obat-obatan atau menderita kondisi psikologis yang tidak baik. Ini harus diidentifikasi oleh seorang dokter. Nah, apa yang harus dirujuk? Ini adalah penyakit-penyakit yang sangat dibutuhkan rujukan dini, diabetes, malnutrisi, penyakit kardiovaskular, hipertensi, anemia. Anemia bukan hanya sekadar kita menduga bahwa itu adalah anemia karena kekurangan zat besi, tapi betul-betul harus didiagnosis apakah anemia ini benar-benar kekurangan zat besi atau ada penyakit lain di belakangnya seperti penyakit-penyakit yang bawaan, thalassemia tadi saya sudah sebutkan, atau penyakit-penyakit kronik yang bisa menyebabkan anemia, HIV, kemudian hipertensi, tuberkulosis, dan juga malaria misalnya harus diidentifikasi dengan baik. Begitu juga kelainan-kelainan yang lain. Nah, kondisi ini yang membutuhkan seorang dokter umum untuk menjembatani antara masalah di komunitas dengan rujukan, yaitu yang nantinya bisa ditangani oleh seorang dokter spesialis, baik spesialis kandungan maupun spesialis lain. Kolaborasi ini adalah hal yang baru, tadi sudah dikatakan oleh Ketua POGI, ini adalah hal yang dibutuhkan untuk menurunkan angka kematian ibu. Tidak bisa lagi kita berpegang hanya pada satu profesi, tapi harus kolaborasi yang baik antara FKTP, FK rujukan, fasilitas kesehatan rujukan, dan juga komunitas. Nah, PNPK rujukan masa hamil sudah kita sesuaikan dengan itu. Juga kita lihat bahwa ANC adalah memilah kondisi ibu yang sehat dengan yang tidak sehat, dan ini harus dilakukan identifikasi dini dan juga dilakukan identifikasi selama masa kehamilan. Alhamdulillah buku KIA revisi 2020 sudah mengakomodir apa yang kita tuliskan di PNPK. Ada pertemuan yang ditambahkan, yaitu 2 kali pertemuan dokter umum dalam PNPK, sehingga jumlah antenatal care menjadi 6 kali. Nah, kolaborasi antar profesi nampak sekali pada buku KIA revisi 2020 ini, dengan kita memberikan kolom-kolom rekomendasi, kita bisa lihat, kemudian screening preeklamsi beserta rekomendasi juga, dan juga pada trimester ketiga, dilakukan juga pemeriksaan secara utuh oleh seorang dokter dan rekomendasi. Nah, screening kelainan medis dan obstetri di trimester 1 dan trimester 3, yaitu K1 dan K5, adalah hal yang khusus yang tidak keluar dari standar kompetensi dokter. USG kita wajibkan untuk dilakukan oleh dokter pada trimester 1 dan trimester 3, dan USG ini sudah berada dalam standar kompetensi dokter. Jadi bukan tambahan kompetensi, tapi sudah merupakan standar kompetensi seorang dokter untuk melakukan USG obstetri dasar terbatas secara mandiri. PNPK lain juga tentang tata laksana komplikasi kehamilan, hepatitis, dan HIV sudah melibatkan dokter. Karena itulah pelatihan blended learning training yang sudah dilakukan oleh Kementerian Kesehatan dalam meningkatkan kapasitas dokter adalah dengan dukungan penuh dari POGI maupun IDAI, dan basisnya tetap pada buku KIA, di mana diberikan kemampuan atau refreshing untuk kemampuan dokter dalam melakukan screening, termasuk ultrasonografi. Dan kemudian kolaborasi dengan dokter spesialis obgyn maupun penyakit dalam di awal ini dilakukan di 120 lokasi kabupaten kota di seluruh Indonesia. Kita berharap dengan PNPK tersebut dan dengan buku KIA tersebut dokter dapat kolaborasi untuk menurunkan angka kematian ibu. Bagaimana dengan rujukan persalinan PNPK yang kita buat terkait dengan pelatihan gawat darurat maternal neonatal yang saat ini juga sudah diselenggarakan dan melibatkan 3 tenaga medis, yaitu tenaga dokter, tenaga paramedis yaitu bidan dan perawat. Sekali lagi tidak mungkin menurunkan angka kematian ibu bila tata laksana persalinan tidak dilakukan secara komprehensif dengan jumlah tenaga medis dan paramedis yang cukup dan terlatih. Nah, modulnya sudah dibuat, pelatihannya sudah dilakukan sejak 2 tahun yang lalu. Komplement yang diberikan lagi oleh Kementerian Kesehatan adalah pendampingan rumah sakit di lokus-lokus percepatan penurunan AKI dan AKB yang juga kita upayakan selalu melibatkan dokter untuk berkolaborasi dengan dokter-dokter di fasilitas pelayanan kesehatan rujukan di rumah-rumah sakit. Nah, yang terakhir adalah Kementerian Kesehatan membuat materi untuk meningkatkan kapasitas bidan dan sekali lagi ini juga dengan kita minta untuk melibatkan dokter. Karena bidan di layanan kesehatan primer kalau dia mendapatkan sesuatu yang dia lihat mencurigakan untuk tidak normal atau di luar batas-batas normal harus segera dikomunikasikan dengan dokter. Stunting dikaitkan dengan bayi berat badan lahir rendah yang tentunya sangat terkait dengan preeklamsi, KEK, anemia, dan juga obesitas. Karena obesitas merupakan faktor atau risiko untuk terjadinya preeklamsi. Karena itulah penyusunan materi ini kita buat komprehensif dan kita memberikan porsi bagi dokter untuk terlibat dalam upaya pencegahan stunting yang dengan sendirinya merupakan upaya pencegahan morbiditas ibu yang bisa berujung atau berarah pada kematian ibu yaitu preeklamsi dan anemia. Nah, inilah seluruhnya yang ingin kami sampaikan dan semoga dengan kolaborasi antara POGI dan peningkatan kompetensi dokter ini kita berharap angka kematian ibu dan angka kematian bayi baru lahir juga dapat diturunkan. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Dan kemudian ini merupakan banyak PR yang bisa kita tanyakan kepada beliau nanti pada audiens, karena waktunya dicatat nanti pada akhir, baru dijawab sama beliau. Kemudian selanjutnya, yang kedua juga tidak jauh dari topik kita dalam era pandemi COVID-19, kita juga prihatin mencoba untuk tetap menjaga layanan yang berkualitas. Untuk ini kami mohon pada Profesor Dr. Muhammad Hakimi, kami persilakan untuk menyampaikan presentasi beliau. Sebelumnya kami sampaikan kurikulum PT tahun 2002, konsultan Obstinsos tahun 81, training di John Hopkins di Baltimore, Maryland, USA, tahun 77, fellowship reproductive health service di Rhode Island, USA juga, tahun 76 adalah spesialis obstetrik ginekologi dari FK UGM. Saat ini beliau adalah staf sosial obstetrik divisi Obstinsos di FK UGM, RSU Dr. Sarjito, Yogyakarta. Kami persilakan Prof untuk menyampaikan waktunya 20 menit dan ditanyakan, dicatat nanti untuk yang setelahnya. Kami persilakan.
Terima kasih Dr. Bambang Prianto. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Karena keterbatasan waktu, skop pembicaraan saya nanti saya batasi pada antenatal care saja ya, yaitu implementasi strategis memberikan pelayanan antenatal care dalam masa pandemi COVID-19 dan sesudahnya. Nah, karena pandemi belum berlangsung lama, kita mungkin akan kesulitan kalau mengumpulkan evidence atau bukti ya. Oleh karena itu yang saya lakukan adalah melakukan scoping review. Jadi tujuannya adalah untuk mendapatkan gambaran tentang penelitian-penelitian apa yang sudah dilakukan ya. Jadi dengan mencari publikasi di electronic database memakai kata kunci COVID-19 dan antenatal care, kemudian itu disajikan secara naratif. Ya, jadi ada 28 artikel yang memenuhi yang relevan untuk kita masukkan dalam presentasi ya. Kemudian ini ditambah beberapa artikel sebelum COVID-19, sebelum pandemi yang relevan untuk ditambahkan. Ini outline dari presentasi saya. Jadi seperti kita ketahui bersama, akhir Desember itu ada laporan tentang kasus dengan pneumonia yang tidak diketahui di kota Wuhan di Cina. Kemudian Januari ini dikenal sebagai COVID-19 dan setelah itu meluas ke seluruh dunia sehingga tanggal akhir Januari dinyatakan oleh WHO sebagai Public Health Emergency of International Importance ya. Kemudian 11 Maret itu dinyatakan sebagai global pandemic. Terus salah satu rekomendasinya adalah dengan melakukan social isolation dari masyarakat ya, dan ini tentu saja berdampak pada pemberian pelayanan kesehatan khususnya untuk ibu hamil. Ya. Nah, sebelum melihat apa yang ada pada selama pandemi, maka ini yang menarik adalah kira-kira hampir 1 dekade ke belakang ya, di jurnal Obstetric and Gynecological Survey sudah ada continuing medical education tentang pemakaian telemedicine di dalam obstetri, ya. Jadi suatu tinjauan pustaka. Ya, yang ada dua yang menarik dari pemanfaatan telemedicine di obstetri tadi ya. Jadi secara garis besar telemedicine itu dapat didefinisikan sebagai transmisi dari informasi medis ya dengan memanfaatkan teknologi telekomunikasi. Dan dari beberapa penelitian itu ternyata bahwa telemedicine ini dilihat oleh banyak dokter sebagai suatu cara untuk meningkatkan efisiensi, kemudian memperluas skop dari praktik dan juga memperbaiki outcome kesehatan. Ya, ini salah satu hasil penelitian. Ya, jadi ini dilakukan di Intermountain Healthcare di Salt Lake City di Utah di Amerika Serikat. Ya, jadi membandingkan ini randomized controlled trial membandingkan antenatal care yang tradisional dengan memakai telemedicine ya pada kehamilan risiko rendah, usia kehamilan kurang dari 16 minggu ya, dengan janin tunggal. Ya. Jadi yang dibandingkan adalah yang antenatal care secara tradisional dengan yang memakai telemedicine dengan hanya 5 kunjungan prenatal yang direncanakan. Ya. Kemudian kontak telemedicine itu memanfaatkan platform berbasis web ya, dan dalam kesempatan itu pasien memasukkan data misalnya tentang berat badan, tekanan darah, dan denyut jantung janin ke dalam portal rekam medis dari pasiennya. Ya. Terus ternyata hasilnya adalah kelompok telemedicine memiliki lebih sedikit kunjungan prenatal di klinik secara signifikan dibandingkan dengan yang kelompok biasa. Ya, kemudian dengan biaya yang terkait dengan kunjungan juga secara signifikan lebih rendah dibanding dengan yang tradisional, dan total waktu yang diperlukan untuk kunjungan juga berkurang. Kemudian satu lagi penelitian tentang telemedicine sebelum pandemi, ya, yaitu di klinik Mayo di Amerika Serikat. Ya, jadi ibu hamil itu dimasukkan ke dalam kelompok kelompok pemeriksaan prenatal yang frekuensinya dikurangi. Ini secara acak, ya, tapi dikurangi jumlah kunjungannya, tapi diperkuat dengan pemantauan di rumah dalam jarak jauh dan dukungan keperawatan. Ya, ternyata mereka mempunyai kepuasan yang lebih tinggi dibanding dengan antenatal care yang tradisional. Juga stres yang terkait dengan kondisi prenatal itu juga berkurang. Dan juga tentu saja kunjungannya juga lebih sedikit, ya. Jadi penelitian ini memberitahu kita apa, ya. Jadi randomized control trial ini meneguhkan kembali bahwa pengurangan frekuensi kunjungan antenatal itu diganti dengan pemantauan secara jarak jauh itu sama efektifnya dengan model tradisional dengan kunjungan 12 sampai 14 kali, ya, dan memberikan kepuasan yang lebih besar, ya, dan stres terkait dengan kondisi prenatal yang lebih rendah. Terus oleh Royal College of Obstetricians and Gynecologists direkomendasikan bahwa ibu hamil selama pandemi itu dikelola dengan komunikasi jarak jauh, ya, untuk klinik antenatal rawat jalan. Ya. Ya, telemedicine dalam obstetri itu meliputi cara-cara berbasis web, ya, seperti video teleconference dan juga telepon consultations, ya. Dengan demikian perlu dipertimbangkan untuk secara kasus demi kasus mana yang sesuai dan juga memperhatikan kebutuhan kalau ada kehamilan risiko tinggi. Ya. Jadi dampak COVID-19 itu tidak hanya mempengaruhi penyediaan pelayanan, tapi juga mempengaruhi sumber daya manusia dan juga mempengaruhi persepsi dari masyarakat. Ini adalah penelitian yang dilakukan di Israel, ya. Jadi karena keterbatasan yang dikeluarkan oleh Kementerian Kesehatan, maka dilakukan penyesuaian jumlah kunjungan antenatal, dan kemudian ternyata yang dialami adalah penurunan dalam semua aspek dari pelayanan obstetri, ya. Jadi bisa kita lihat dalam grafik ini, jadi kunjungan untuk triase obstetrik menurun, kunjungan untuk triase ginekologi juga menurun, kunjungan klinik risiko tinggi menurun, kunjungan ke unit USG menurun, dan kunjungan ke unit risiko tinggi juga menurun. Terus kalau dibandingkan dalam bulan Maret-April 2020, ya, dengan bulan Maret-April setahun sebelumnya, ya, 2019, ternyata perbedaannya tidak bermakna ya dalam angka berdasar dan outcome yang lain baik pada ibu maupun bayinya ya. Yang berbeda adalah hanya yang berbeda secara signifikan adalah pertolongan persalinan perbagian secara operatif terjadi kenaikan yang signifikan ya. Kemungkinan ini disebabkan karena angka kejadian kehamilan risiko tinggi yang bertambah karena pandemi COVID-19. Ya, terus ini di di kota New York juga dilakukan penyesuaian pelayanan kesehatan. Ya, ternyata dasarnya adalah bahwa penyesuaian itu akan mengurangi jarak tempuh ke tempat pelayanan, dengan demikian mengurangi paparan terhadap COVID-19. Ya. Ya. Terus yang dapat kita pelajari adalah meskipun kunjungan telehealth secara virtual itu tidak bisa menggantikan sepenuhnya dengan kontak langsung ya, tapi ini bisa dimanfaat untuk mengurangi paparan pasien dan pemberi pelayanan kesehatan terhadap COVID-19. Dan pelayanan diberikan itu dapat dimodifikasi untuk menyesuaikan diri dengan kebutuhan pada pasien risiko tinggi. Yeah. Saya kira key points itu nanti akan saya angkat menjadi take home message-nya. Dari WHO ini kemudian diusulkan ada paradigma baru, ya, yaitu perawatan sendiri ya. Jadi ibu hamil itu didorong untuk melakukan perawatan sendiri dan juga diberikan pelayanan dalam jarak jauh ya melalui telehealth. Nah, tentang bagaimana kualitas pelayanan ya, jadi kalau kita lihat salah satu aspek kualitas itu adalah pertukaran informasi dan hubungan interpersonal. Maka beberapa penelitian menunjukkan bahwa ini ada 75% responden itu menyatakan puas dengan model tersebut ya, dan pengalaman yang positif itu meliputi kemudahan untuk akses dan sebagainya. Ya, saya harus meloncat karena waktunya. Nah, POGI juga sudah mengeluarkan ini rekomendasi tentang kesehatan ibu pada pandemi COVID-19. Di dalam rekomendasi ini ada juga kata telehealth, ya, yaitu pada kehamilan trimester kedua itu dianjurkan untuk memakai telekonsultasi. Pengertian strategik itu adalah dari yang level yang tinggi di organisasi ya, dan ini bisa dalam jangka lama ya, dan yang dipelajari dari pelayanan antenatal selama COVID-19 itu adalah bahwa sebagian dari pelayanan itu dapat dilakukan dengan telemedicine atau telehealth ya, dan bahkan diperkirakan bahwa perubahan yang terjadi ini tidak bersifat sementara tapi akan merubah pelayanan kesehatan dalam jangka yang panjang ya. Dan ini mungkin akan penting artinya untuk asuransi kesehatan ya. Jadi dikatakan bahwa kita itu sebenarnya sudah agak terlambat ya untuk melakukan mendesain kembali pelayanan yang lebih efektif, efisien dan dan merata ya. Jadi mungkin krisis ini memberi kesempatan pada kita untuk melakukan perubahan yang kita inginkan tersebut. Ya, jadi maaf sebelum tadi ya, jadi ini ya kesempatan karena apa hanya krisis yang bisa apa betul-betul akan bisa memberikan perubahan ya. Jadi ini perubahan dalam pelayanan kesehatan karena COVID-19. Jadi yang bisa kita pesan yang bisa dibawa pulang adalah telehealth itu untuk prenatal care itu bisa dikerjakan. Ya, kemudian telehealth bisa mengurangi paparan coronavirus dalam asuhan prenatal, dan kemudian telehealth ini perlu disesuaikan untuk kehamilan risiko tinggi. Ya, baik, itu yang bisa saya sampaikan. Terima kasih atas perhatiannya, semoga bermanfaat. Assalamualaikum warahmatullahi wabarakatuh. Waktu saya kembalikan ke Dr. Bambang Trianto.
Ya, terima kasih Profesor Muhammad Hakimi atas presentasinya. Telah disampaikan bahwa di dalam era pandemi ini masih ada sisi-sisi ilmiah, statistik, epidemiologik yang bisa kita lakukan untuk efisiensi dan mencegah penularan. Terima kasih sekali lagi, dan para pendengar, audien bisa langsung mencatat pertanyaan dan dikirimkan ke panitia, nanti dijawab setelah selesai semua presentasi. Yang ketiga, kita tentunya ingin bahwa apa yang kita lakukan terhadap sesuatu yang sifatnya emergency, menjadikan suatu derita masyarakat banyak, ini diikuti dengan sesuatu yang sesuai dengan prosedur. Bagaimana terlayani sebagai manusia seutuhnya. Jadi dalam hal ini etik tidak boleh kita tinggalkan. Kita mencoba di sini yang pembicara yang ketiga kita dengarkan, ada dua pembicara, yaitu yang pertama Dr. Tono Hadi Susiarno, kemudian yang kedua nanti Prof. Jamhur. Kemudian Dr. Tono kami bacakan sisi kurikulum PT-nya, 2012 doktoral program di Unisba, 2006 Social Obstetric Consultant, 2005 Magister of Health FK4, tahun 2000 spesialis Obgyn. Sebagai saat ini adalah Kepala Divisi Obgyn Sos di FK4 Rumah Sakit Hasan Sadikin. Kami persilahkan Dr. Hadi Susiarno untuk menyampaikan makalahnya.
Baik, terima kasih moderator, Dr. Bambang yang saya hormati. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih saya telah diberi kesempatan bersama Prof. Jamhur untuk menyampaikan masalah etik pada pelayanan kesehatan. Namun perlu saya sampaikan bahwa dengan waktu yang singkat, hanya 20 menit, dan sementara pembicara ada dua, oleh karena itu saya akan menyampaikan mengenai kasus yang terjadi pada masa COVID. Dan nanti Profesor Jamhur akan menyampaikan tentang pembahasannya mengenai kasus-kasus yang saya sampaikan ini. Mohon izin saya akan membuka share screen-nya. Saya bisa. Oke. Yang pertama, seorang pasien umur 24 tahun, umur 42 tahun maksud saya ini, jumlah anak 8 orang, persalinan semua rumah sakit pendidikan. Hasil swab positif, sementara peserta BPJS. Pasien dan suami ingin segera dilakukan steril sebelum pulang. Masalahnya di sini kita tahu bahwa sterilisasi adalah merupakan tindakan operatif, ya. Walaupun memang tindakannya kecil, tapi di masa COVID ini akan berdampak terhadap sarana dan fasilitas yang harus tersedia. Yang menjadi permasalahan di sini adalah apakah steril perlu dilakukan segera atau ditunda. Permasalahannya kalau ditunda ini masuk ke dalam unmet need, ya. Kita tahu bahwa tindakan pasien tidak emergensi, sementara fasilitas APD sangat terbatas. Kita tahu bahwa APD yang diperlukan pada waktu tindakan steril cukup banyak, ya, terdiri dari operator, asisten operator, kemudian anestesi, residen, kemudian juga instrumen dan envelop dan lain-lain, ya. Bila tidak terpenuhi permintaan pasien, cenderung pasien akan hamil kembali sehingga dengan resiko yang lebih tinggi, ya, untuk terjadi kehamilan yang akan datang. Kita tidak bisa percaya bahwa pasien ini akan datang kembali untuk melakukan sterilisasi kalau sudah pulang. Kemudian kasus yang kedua, kasus yang kedua, bentar, oke. Ya. Oh, bukan, sorry. Bukan ini kasus yang kedua. Oh, sama ini. 1, 2. Oh, sama ini. Bentar, mohon maaf, ini ada kesalahan share screen. Tuh, mohon maaf sebentar. Bentar, satu lagi akan saya bacakan saja. Ini kasus yang kedua adalah bahwa seorang pasien G1, G2, P1A0 ya, dengan riwayat persalinan pertama normal dengan kehamilan cukup bulan setelah dilakukan observasi positif. Pasien disarankan persalinan di rumah sakit rujukan dengan COVID-19. Ya. Dengan COVID. Ya. Seorang pasien G2 P1A0 riwayat persalinan pertama normal dengan kehamilan cukup bulan setelah dilakukan swab hasil positif. Pasien disarankan persalinan di rumah sakit rujukan COVID-19. Tetapi pasien menolak dan ingin melahirkan di PPK1. Masalahnya, bagaimana tindakan kita sementara dokter harus menghargai hak otonomi pasien. Di lain pihak, kita tahu bahwa COVID-19 menularkan orang banyak. Apakah kita bisa melanggar hak pasien demi kepentingan umum? Itu yang mungkin yang saya sampaikan, Pak Moderator, saya kembalikan. Kemudian nanti selanjutnya kepada Profesor Jamur untuk membahas kedua kasus ini. Terima kasih, Dr. Bambang. Terima kasih. Saya kembalikan kepada Dr. Bambang sebagai moderator. Terima kasih, Pak Moderator.
Ya. Oh ya, kita lanjutkan dengan Prof. Jamjur. Mungkin sudah siap beliau akan mengkupas mengenai sisi etiknya dengan beberapa hal latar belakang dan aturan yang saat ini bisa yang masih berlangsung. Kami persilahkan Prof. Jamhur. Kurikulum QT-nya kami bacakan, tapi belum keluar ini. Coba kita tunggu sebentar.
Izin, belum ada kiriman CV-nya.
Ya, saya
Jadi
kira
mungkin
gini,
bisa dilanjutkan
Prof. Jamhur
saja.
ini pertama jadi dokter, beliau dokter Angkatan Laut di Surabaya. Saya masih ingat, saya pernah ditunjukkan, ini loh rumah saya Pak Bambang, rumah dinas maksudnya. Terus kemudian di Bandung mengembangkan sebagai seorang pendidik, kemudian S3 dengan mulai dari dosa, terus akhirnya jadi guru besar sampai sekarang secara tekun mereka mendampingi Obstinsos di FK, Unpad, dan masih aktif di dalam mendidik baik itu S1, S2 maupun S3. Kami persilahkan Prof. Jamhur. Halo? Halo, sudah bisa connect dengan Prof. Jamhur? Halo?
Prof. Jamhur.
Halo?
Prof. Jamhur.
Halo, Prof. Jamhur. Ya, silakan Prof. Jamhur. Silakan. Ini waktu untuk Prof. Jamhur. Ya. Selamat siang, Prof. Ya.
Tugas ini ditugaskan pada saya oleh PB Pogi dengan judul Aspek Etik Pelayanan Maternal selama masa COVID. Kita tahu bahwa kita tahu bahwa kalau kita memberikan pelayanan pada pasien, kita harus bertindak sebagai profesional. Jenis profesional itu adalah, menurut saya ada 4. 1, mempunyai ilmu dan teknologi kedokteran yang mutakhir. 2, mempunyai keterampilan klinik yang sesuai dengan standar prosedur. 3, mempunyai niat, sikap, dan perilaku yang etis. Dan 4-nya, mempunyai sifat kepemimpinan. Jadi ke-1 dan ke-2 disebut kompetensi klinik atau cure. Jadi ketiga disebut kompetensi etik atau care. Cure itu ditujukan kepada penyakitnya, sedangkan care ditujukan kepada orang sakitnya. Jadi pelayanan kesehatan yang paripurna adalah gabungan dari cure dan care yang proporsional. Sikap etis terhadap pasien itu, nah itulah yang disebutkan etika klinik. Etika klinik itu ada pengertian. Salah satunya dari BSM dan Childress. Mereka mengatakan kalau kita memberikan pelayanan harus memenuhi 4 syarat. Pertama, beneficent. Segala sesuatu yang dilakukannya hanya untuk kepentingan pasien. Kedua, normatif. Harus dijaga agar Ketiga, otonom dalam menentukan keputusan klinik dalam keadaan yang setara. Keempatnya adalah justice. Seluruh masyarakat mempunyai hak yang sama untuk mendapat pelayanan kesehatan yang baik pada waktu mereka memerlukannya. etika klinik ada perkembangannya. Etika klinik telah mengalami perkembangan yang substansial. Sampai sekarang ada dua istilah etika dalam kedudukan kedokteran, yaitu etika klinik dan bioetika. Etika klinik adalah pedoman yang harus ditaati oleh para klinisi dalam menjalankan tugasnya, sedangkan bioetika mempunyai pengertian yang lebih luas dan baru dikenal sejak beberapa dekade terakhir. Menurut Callahan, bioetika mempunyai dua perspektif. Satu, merupakan kajian modern yang mencolok dan dalam bidang biomedis, lingkungan. Yang keduanya, menemukan lagi permasalahan lama, yaitu tentang arti kehidupan, sakit, penderitaan, dan kematian. Bioetika merupakan transformasi radikal dari etika klinik yang tradisional sejak zaman Plato. Bioetika dalam pengertian sekarang menjadi otonom, pluralistik, dan sekuler. Menurut Hans Martin, bioetika mempunyai pasien dan dokter. Setelah tradisi, ekspertis dan etika, maksudnya ekspertis itu cure dan etika itu care. Setelah tradisi, ekspertis dan etika selalu mempunyai kesatuan. Etika tanpa ekspertis tidak akan efektif. Sedangkan ekspertis tanpa etika tidak membawa kebaikan bagi pasien. Bioetika ada dua. Ada bioetika makro, yaitu di mana ada pihak-pihak lain yang terlibat di dalamnya, seperti direktur rumah sakit, asuransi kesehatan, dan lain-lain. Sedangkan bioetika mikro menggambarkan hubungan pasien dengan dokter. Itulah yang disebut etika klinik itu. Peristiwa kehamilan adalah suatu peristiwa yang penting bagi satu keluarga. Mereka mengharapkan bahwa anaknya akan membawa nama baik dari magelanya, serta menjadi generasi penerus yang baik bagi bangsanya. Kita tahu bahwa kegiatan maternal itu terdiri dari 3, antenatal care, intrapartum care, dan postpartum care. Sedang itu adalah infeksi yang disebabkan oleh virus severe acute respiratory coronary virus. Ibu hamil dengan COVID-19, kesehatan ibu dan anak akan terganggu. Bagaimana hubungan antara ibu hamil dengan COVID-19 dengan etika klinik? Dokter itu bisa tidak etis kepada dirinya dan bisa juga tidak etis kepada pasiennya. Dokter itu tidak etis kepada dirinya kalau ilmu dan teknologinya sudah kadaluarsa dan keterampilan kliniknya tidak sesuai dengan standar prosedur. Berarti dokter itu tidak pernah belajar lagi. Dokter berlaku tidak etis terhadap pasiennya kalau tidak melakukan informed consent dengan benar. Apa itu dokternya? Informed consent itu adalah satu informasi yang diberikan kepada dokter, yang diberikan oleh dokter kepada pasien atau keluarganya tentang diagnosis penyakit, terapi, dan menurut Buchen dan Hedan, informed consent yang benar harus mengandung 5 unsur, yaitu pemberian informasi, disclosure, pemahaman, compression, kehamilan, kesukarelaan, voluntarisme, kemampuan kompeten, dan izin consent. Jadi ada yang sebetulnya consent itu izin atau otorisasi yang diberikan diberikan secara sukarela oleh pasien yang kompeten kepada dokter untuk melakukan sesuatu tindakan terhadap dirinya yang dianggap baik setelah pasien itu mendapat informasi yang jelas dan dapat dipahaminya. Selama ini belum diketahui bagaimana cara menangani ibu hamil dengan COVID-19. Oleh karena itu, PBPOG mengajukan rekomendasi yang rekomendasi itu berupa rekomendasi penanganan infeksi virus corona COVID-19 pada maternal, hamil, bersalin, dan nifas. Kita mulai dengan antenatal. Kalau antenatal untuk ibu hamil dengan COVID, si ibu harus segera dirawat di ruang isolasi khusus. Pemeriksaan laboratorium tetap bisa dilakukan. Pemeriksaan USG diundur sampai isolasi berakhir. Pengobatan di luar penelitian harus dipertimbangkan risk benefitnya. Perawatan antenatal selanjutnya dilakukan 14 hari setelah masa akut berakhir. Bila ibu hamil dengan COVID-19 datang dalam keadaan buruk, harus dibentuk tim multidisiplin yang terdiri dari dokter ahli infeksi, SPOG, dokter anak, dokter anestesi, dan bidan. Prioritas utama adalah perawatan medis dengan lokasi yang tepat. Memberikan dan terapi suportif, kemudian evaluasi kondisi ibu dan janin, termasuk pemeriksaan detik jantung janin. Pemeriksaan radiologi harus hati-hati karena bisa merugikan janinnya. Stabilisasi ibu merupakan keharusan. Bila terjadi komplikasi seperti preeklamsi berat, harus dilakukan secara sesuai dengan SOP. Keputusan untuk melakukan persalinan perlu dipertimbangkan kalau persalinan itu bisa membantu efektivitas resusitasi ibu atau keadaan janin yang memburuk. Pemberian kortikosteroid untuk pemandangan paru-paru janin harus dikonsultasikan dan dikomunikasikan dengan tim dokter yang merawat. Bagaimana dalam menghadapi intervensi? Tim medis yang ada di kamar bersalin jumlahnya harus seminimal mungkin. Hanya seorang dari keluarga yang boleh menunggu dengan menggunakan APD. Pengawasan pasien seperti biasa ditambah dengan saturasi oksigen sampai 94%. Pengawasan janin dilakukan secara kontinu. Sampai sekarang belum ada bukti cara persalinan yang terbaik itu bagaimana. Setiap tindakan harus ada indikasinya. Sehingga kecuali bila ada gangguan respirasi sehingga diperlukan tindakan sesaria atau operasi perpakaian. Bila ada indikasi operasi terencana, operasi harus dilakukan dengan cepat sesuai dengan SOP-nya. Bila ada perburukan, lanjutkan operasi atau lakukan seksi darurat. Ibu hamil dalam keadaan 2 serta harus dilakukan tindakan konsep atau vakum. Postmortem seksi usaha bisa dilakukan apabila ibu mengalami kegagalan resusitasi tapi janin masih viable. Tiap orang operasi mempunyai syarat. Satunya operasi, kalau kita melakukan operasi elektif pada pasien COVID-19 harus dijadwalkan pada terakhir. Pasca operasi, ruangan operasi harus dibersihkan sesuai standar. jumlah petugas seminimal mungkin. Petugas kesehatan di kamar bersalin harus memenuhi standar kontak dan droplet precaution, termasuk menggunakan APD sesuai dengan panduan PPI. Antibiotika intrapartum harus diberikan sesuai protokol. Pemotongan tali pusat harus diundur, kecuali bila ada komplikasi. Pengeluaran plasenta seperti biasa, tapi bila diperlukan pemeriksaan histologis dari plasenta, petugas laboratorium harus diberitahu bahwa penjaringan yang dikirim itu berasal dari pasien COVID-19. Anestesi yang dilakukan hanya epidural dan spinal. Anestesi umum harus merupakan pengecualian. Tim nasional harus diberi tim neonata harus diberitahu tentang kelahiran anak dari ibu dengan COVID-19. Jadi keharusan menggunakan APD merupakan bukti bahwa petugas kesehatan telah bersikap etis. Bagaimana performannya? Sudah melahirkan, ibu dipisah dari bayinya selama 14 hari. Kalau ingin merawat sendiri, harus tahu akan kemungkinan penularan dan diisolasi dalam kamar dengan fasilitas ensuite dengan syarat-syarat. Bayi ditempatkan di dalam inkubator tertutup dalam ruangan. Ketika sedang menyusui, ibu harus memakai APD dan diajarkan mengenai etika patut. Bayi harus keluar dari ruangan bila ada kegiatan yang menghasilkan aerosol. Sampai sekarang belum ada bukti terjadinya mother to child vertical transmission. Harus dibuktikan bahwa sudah bayi lahir, harus dibuktikan bahwa si bayi sudah tertular atau belum tertular COVID-19. Pemulangan pasien sesuai dengan pemulangan pasien COVID-19. Yang perlu diketahui ibu hamil dengan COVID-19 tentang menyusui. Sebaiknya si ibu tidak menyusui sendiri. Tapi kalau menyusui sendiri ada syaratnya. Pertama, cuci tangan dulu. Kedua, menggunakan masker. Setelah selesai, pompa ASI difungsikan. Kalau perlu, minta bantuan orang lain. Ibu bisa memerah ASI bila menggunakan pompa. Pompanya harus dibersihkan dan disinfeksi. Kantong ASI harus ditandai dan dibawa keluar ke lokasi yang sudah ditentukan. Dengan cara memberikan pelayanan kepada ibu hamil dengan COVID-19, petugas medis sudah melaksanakan aspek etikanya terbukti dari pertama menggunakan protokol kesehatan, sebelumnya memberikan dahulu info konsen, para petugas menggunakan APD, dan dalam bertindak mereka bersikap penuh empati, sabar, jujur. Kesimpulan, ibu hamil dengan COVID-19 harus ditangani secara spesifik. Sampai sekarang belum ada pelayanan yang seragaman. Semua kegiatan seperti anteinternal dan postpartum harus dilakukan sesuai dengan hasil etiknya. Terima kasih.
Ya, terima kasih Prof. Ya, jadi tadi telah disampaikan mengenai ini kembali ke basic adanya etik ya, kita diingatkan kembali, kemudian dikaitkan dengan masa pandemi ini. Dari beberapa MC-nya ini langsung tanya jawab ya.
Iya betul
Benar,
dok.
Dok.
Langsung
Ya,
tanya jawab
langsung
dokter.
jawab. Saya
Iya,
lihat
dok.
di sini Dokter Prof. Dwi Okvianti sudah ada 3 penanya. Kemudian Prof. Muhammad Hakimi ada 2 dan yang lainnya menyusul. Dan kemudian yang belum sempat nanti dicatat, kemudian disampaikan karena kita tahu contohnya Prof ini ketemunya paling mudah sekarang. Kalau besok ini sudah lari ke Kemenkes, lari ke dekanat, lari kemana. Jadi saat ini yang paling bagus menurut saya, karena bisa tatap muka. Kami persilahkan, mungkin sudah ada yang di filenya sudah disampaikan. Terima kasih. Oh enggak?
Baik, Prof. Baik, Dokter Bat. Terima kasih. Jadi ada yang terbaca oleh saya ada 2 pertanyaan. Yang pertama adalah bagaimana peran profesi lain seperti ahli gizi, psikolog, ahli sanitasi lingkungan dalam mendukung dan teknik. Nah, ini benar sekali karena tadi dalam apa yang sudah saya sampaikan pada paparan kan kita lihat bahwa apabila ada masalah medis pada ibu atau diidentifikasi ada faktor risiko pada ibu, termasuk faktor risiko itu bisa masalah kejiwaan, kan sehat bukan hanya sehat fisik, tapi juga sehat secara kejiwaan dan juga sehat sosial. Nah ini dua hal inilah yang harusnya kita identifikasi pra-konsepsi. Nah ini perlu kolaborasi tentunya dengan psikolog, dengan bahkan dengan pemerintah, dengan masyarakat. Tadi kita lihat kolaborasi dokter itu adalah dengan masyarakat, di samping dengan para ahli. Contohnya yang paling banyak kejadian yang kita terima kasus yang buruk itu adalah obesitas atau KEK. Itu tidak mungkin hanya diberi makan ibunya atau hanya dibatasi makannya, tapi betul-betul seorang ahli gizi harus terlibat dalam melihat evaluasinya. Apakah makanannya sudah cukup atau tidak, atau kelebihan dan sebagainya. Nah, untuk yang kedua adalah tentang kematian ibu. Tadi dikatakan bahwa kematian ibu itu sangat mungkin sekali memang trennya untuk meningkat, begitu juga di Jawa Timur ya. Tapi tadi yang kita katakan tidak usah putus asa. Rujukan-rujukan ini bisa saja terjadinya pada pandemi ini karena memang ibunya takut untuk datang ANC atau takut bidannya juga takut untuk menerima. Nah ini kita sudah kerjasama sekarang. Tadinya waktu awal-awal kan kita katakan bahwa ANC tidak usah terlalu sering. Sekarang tidak, tetap ANC pada ibu hamil strict harus minimal 6 kali. Kemudian pemeriksaan pada kondisi ada kasus-kasus yang masalah medis tetap harus dirujuk seperti apa adanya. Nah standar-standar sudah dibuat bersama-sama antara POGI juga dengan Kementerian Kesehatan sehingga seluruh pemberian pelayanan kesehatan tidak terlalu trauma atau takut pada tahu bagaimana cara menata laksana pada masa pandemi ini. Nah yang terakhir mungkin dari Dr. Hussein Habibi terkait dengan pendampingan rumah sakit, mohon penjelasan tentang model pendampingannya. Nah ini yang sedang kita diskusikan dengan pihak Kemenkes, bahwa pendampingan tentunya intinya adalah supervisi. Tapi pendampingan juga bersangkutan dengan upaya meningkatkan kualitas atau meningkatkan kompetensi. Kompetensinya sudah ada pada dokter umum contohnya. Tapi bahkan dokter umum yang di rumah sakit pun kan belum bisa melakukan ultrasonografi, screening untuk seluruh kasus. Nah ini juga bisa dilakukan, jadi rumah sakit bisa melakukan apapun yang ada pada modul-modul. Kita sudah punya minimal 2, modul gawat darurat maternal neonatal dan modul untuk penguatan KIA ANC dengan buku KIA revisi 2020 yang sekarang dipelatihkan dengan blended learning dan yang akan datang tentang gizi. Jadi kita persilakan memanfaatkan modul-modul ini. Tidak ada hak cipta atau hak prerogatif, seluruh rumah sakit yang diberi tanggung jawab untuk mendampingi dapat menggunakan modul yang ada, atau kalau misalnya masih belum bisa menggunakannya, nanti itu yang dibantu oleh POGI, Pokjapaki, dan juga Hoksi untuk membantu melatihkan ya Pak Bat ya, agar semua objin yang ada di rumah-rumah sakit ini mampu membantu fasilitas di bawahnya seperti FKTP dan juga para dokter umum, dan bahkan memberikan pelatihan pada para bidan. Terima kasih, mungkin itu jawaban dari saya. Terima kasih Pak Bat.
Ya, karena ini sementara sudah dijawab, mungkin berikutnya kepada Profesor Muhammad Hakimi, kalau sudah ada pertanyaan yang tersedia, kami persilakan menjawab.
Ya, pertanyaan dari Dr. Suryo Hadiono. apakah kita sudah mulai melakukan surveillance terhadap strategic implementation yang dilakukan di Indonesia? Oleh karena respons masyarakat dan sistem kesehatan mungkin berbeda di Indonesia dan di negara lain. Ya, sayang sekali ketika saya melakukan penelusuran artikel di Medline, ketika melakukan scoping review itu, dari 68 artikel itu tidak ada satupun yang dari Indonesia ya. Jadi saya tidak bisa menjawab pertanyaan ini, tapi mungkin ada narasumber yang lain mungkin punya informasi. Prof. Ufi mungkin. Tapi saya kira memang kita penting ya, karena kita tidak bisa meniru begitu saja yang dikerjakan dan pengalaman yang didapat dari luar ya. Kita harus menyesuaikan dengan situasi dan kondisi di Indonesia. Dan sayang sekali saya tidak mempunyai sumber untuk menjawab pertanyaan Dr. Hadian Suryo. Saya kira itu Dr. Bambang Trianto. Saya hanya ada satu pertanyaan. Dr. Hussein Habibi, ya, terkait dengan telehealth dan telemedicine mungkin cocok diterapkan kepada ibu hamil di perkotaan. Tapi bagaimana dengan masyarakat kita yang mayoritas tingkat pengetahuannya yang masih rendah dan penggunaan teknologi IT yang juga dipertanyakan kemampuannya. Ya ini
Bambang lupa matiin.
Ya, saya kira ya benar sekali kita perlu hati-hati untuk menerapkan itu. Ya tidak, saya kira tidak sepenuhnya telemedicine dan telehealth yang dilakukan di negara maju itu bisa kita terapkan di sini ya, karena itu tadi ya, secara karena dasar dari telemedicine dan telehealth kan teknologi informasi ya. Ya kalau itu masih belum bisa diandalkan ya pasti kita harus memikirkan cara bagaimana melakukan itu di setting di Indonesia. Ya saya kira itu. Terima kasih. Saya kembalikan Dr. Bambang Trianto.
Ya, kemudian Dr. Tono Hadi Susyarno mungkin sudah ada pertanyaan.
Baik, ini terima kasih. Pertanyaan dari Dr. Suryo. Ini betul, saya setuju bahwa pasien menginginkan sterilisasi. Kita sebagai dokter tidak serta-merta menolak hanya karena adanya COVID-19. Namun ada beberapa alternatif ya agar tidak terjadi unmet need. Oleh karena itu kita memberikan edukasi, konseling, dan sekaligus juga melakukan informed consent dan melakukan informed choice. Memilih satu dari dua alternatif yang kita tawarkan dari mengacu kepada keuntungan dan kerugiannya ya dalam steril ini. Jadi bisa ditawarkan yang kedua adalah saya setuju Dr. Suryo, yaitu alternatif yang kedua penggunaan IUD ya. Bila tidak memungkinkan untuk dilakukan sterilisasi dengan APD yang sangat terbatas. Jadi itu mungkin ini sepertinya Dr. Suryo bukan bertanya tapi hanya memberikan saran. Tapi saya setuju apa yang disampaikan oleh Dr. Suryo. Tentunya kita juga harus melakukan edukasi dan konseling. Jangan sampai nanti ya kalau sudah diberikan IUD ternyata angka kegagalan IUD ini lebih besar daripada steril dan nanti akan menjadi komplain. Oleh sebab itu informed consent pun perlu dilakukan agar tidak terjadi hal-hal atau masalah-masalah di masa yang akan datang. Terima kasih.
Ya, terima kasih. Kalau tidak ada, mungkin Prof. Jamhur ada pertanyaan, Prof. Enggak? Silakan. Atau mungkin melengkapi lah tadi apa? 2 kasus tadi kan belum diulas secara spesifik dari Pak Tono.
Sampai sekarang ada pertanyaan untuk saya. Terima kasih.
Oh iya. Ya. Baiklah, saya hanya ada satu mungkin untuk Prof. Oktober ya. Jadi kita dihadapkan pada basicnya, mencetak dokter. Dalam era pandemi mulai Februari sampai sekarang, kualitas pendidikan terutama yang mungkin kompetensi itu bisa bagaimana. Lah untuk menjadi akhirnya lulus dengan kompetensi yang bagus, itu menjadi tugas berat kita. Kita tadi pendampingan meningkatkan dokter itu menjadi tugas berat. Nah, ini bagaimana selanjutnya, karena basic pendidikan kita di Fakultas Kedokteran, baik itu dokter maupun PPDS. PPDS sekarang pun ini juga kasusnya jarang. Kasus jarang. Kalau dulu vaginal hysterectomy itu seperti bahasa Jawanya segojangan, lah sekarang ini aduh susah, apalagi itu yang masih gimana?
Baik, terima kasih pertanyaannya Pak Bat. Jadi memang untuk pendidikan dokter ini karena pendidikan profesi itu mau tidak mau harus bertemu dengan pasien. Saat ini sih saya rasa saya lihat dari lamannya AIPKI juga para dekan di seluruh Indonesia bertahap kita sudah bisa melakukan pelatihan atau modul-modul yang harus masuk ke klinik, tapi tentunya dengan APD yang lengkap. Tapi sebetulnya ada keuntungan dari masa ini yang kita juga dapat di UI kebetulan. Rupanya dengan adanya work from home ini, sebagian dosen harus di rumah dan tidak bepergian kemana-mana, itu ternyata tatap muka dengan dosen itu malah lebih banyak. Ya karena apa? Jarang yang cancel. Kuliah tepat waktu, kemudian diskusi banyak, bahkan mau diskusi jam berapa saja kadang-kadang. Nah ini tinggal kembali lagi memang koordinasi dari dekan dan wakil dekan dan juga manajer-manajer untuk memperhatikan, sehingga kita merespon ini dengan memberikan kesempatan lebih banyak pada mahasiswa, karena kompetensi keterampilan kan tidak hanya di tangan. Dokter lebih banyak pada pembuatan analisis dan sudah banyak video-video yang sekarang bisa mensupport. Pelatihan kami di 120 kabupaten juga alhamdulillah bisa terlaksana dengan baik karena tidak tergantung dokternya ada di mana saja, bisa dilatih dengan baik ya. Pada saat dia OJT tentunya baru dia datang ke tempat fasilitator. Jadi memang alhamdulillah ada keuntungan dengan pandemi ini, bahwa kita menemukan era di mana komunikasi bisa tidak terbatas waktunya dan karena kita kurang bepergian, tidak ada yang kena macet dan sebagainya, waktu lebih efisien dan efektif, Pak Bat. Semoga ini perbaikan juga untuk pendidikan kita. Terima kasih.
Ya. Terima kasih kepada ketiga pembicara. Yang pertama Prof. Oktober, Yanti dan Mbak Hakimi, kemudian Prof. Jamhur, dan kemudian Dr. Tono Hadi Susi Yarno, dan tentunya dengan Matia Pelaksana dan didukung oleh POGI yang bisa melaksanakan secara digital, conference maupun workshop. Kami kembalikan ke Dr. Yoga, kami persilakan.
Baik, terima kasih banyak kepada Prof. Ovi, Prof. Hakimi, Prof. Jamhur, dan Dr. Tono atas ilmunya yang sangat bermanfaat dan menarik, dan Dr. Bambang yang telah memimpin jalannya acara ini. Okay, ladies and gentlemen, now we've come to our second session, controversies. We will discuss about current evidence of adolescent reproductive health service, who will be led by our chairperson, Dr. Aryeta Pusponegoro, SPOG Consultant. Next, I'll read the CV of the chairperson. Dr. Aryeta graduated Obstetric and Gynecology Specialist from Universitas Indonesia, then took Social Obstetric and Gynecology Consultant in Universitas Indonesia, and doctoral program also in Universitas Indonesia. Currently, Dr. Aryeta is a staff in Obstetric and Gynecology Department, Faculty of Medicine, Universitas Indonesia. To Dr. Aryeta, the time is yours.
Yeah. Thank you, Dr. Yoga. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. It's nice to have you all. We'll come to the second session about current evidence in reproductive health, adolescent reproductive health. We have three speakers, and the speakers will present their presentation for about 15 minutes each, and then we have discussion, especially about controversies in adolescents' reproductive health. The first, we have distinguished guests from Australia. We have Professor Sonia Grover, MBBS, Franz Koch, medical doctor, and let me see first. And she is a director of gynecology in Royal Children's Hospital and gynecologist in Austin Health, Melbourne. She will be presenting the role of ONG specialists, especially in the area of adolescents' reproductive health. And she will be talking about global perspective in adolescents' reproductive health and the importance of PANG, pediatric adolescents gynecologist specialist. And then we will have a discussion, hopefully interesting discussion. Please, Sonia, please present your presentation for about 15 minutes. And then if we have only 5 minutes left, there will be a ring of a bell to remind us all. Thank you. You can start your presentation.
Thank you. I'm hoping you can all see my screen, and thank you very, very much for the opportunity to speak at your digital conference. So thank you for the invitation and the honour of speaking to you today. Just to put our countries into perspective, you are my northern neighbour. You do have 10 times the population that we have in Australia, and you say that we have a great big country, but the vast, vast, vast majority of our mostly one island is actually desert and uninhabitable. So there's considerable differences between your country and my country, but we are neighbours, and therefore sharing is always valuable. So I'd like to start with a global perspective about why thinking about young women is such an important thing. Girls and adolescent girls aged up to 19, actually make up 30% of the world population. And yet there are some very special things about the healthcare needs of these young people that is often not taught in general obstetrics and gynecology, and it's often an area that's missed in pediatrics, it's missed in pediatric surgery, and so there's a gap in the healthcare needs of these young people that I think is a really important area. Continuing with that global perspective, I think it is worth us stopping and thinking about where the world is heading and what this means for our children, our grandchildren, as well as the young women we are caring for. If we do nothing about climate change, then the world will be a very, very different place in 10 and 20 years' time. There's been clear predictions that there will be substantially increased numbers of deaths due to malnutrition, malaria, diarrhea, and heat stress. I know we can all add that COVID's also an issue and that the risk of other pandemics may also have an impact. We do know that amongst the impact of climate change, that the children are most likely going to be affected, and it's going to be the children in developing countries that are going to be by far the most affected. So these changes are likely to have a significant impact. And we know that those changes have an impact on increasing lung disease, increasing asthma, increasing prematurity amongst our obstetric patients, increasing the risk of low birth weight children. We also know that all the changes provoked by climate change, with the increased weather changes and environment stresses, that's going to have an enormous impact on parents, and therefore there's also going to be reduced social supports as countries struggle. And we know that as a consequence of that, there's going to be increased neglect and increased abuse. And again, this is going to affect girls, probably more than boys. And we know that there's going to be increased population displacement. All of this has an enormous impact on girls and young women. And unfortunately, that impact is greater on the young women than it is on the boys. These are the people that you and I, as obstetricians and gynecologists, focus our care on. So we, as gynecologists, the lucky individuals who've had the good fortune to have an education, do need to be taking some responsibility and some action for the future of our children, our grandchildren, and in particular, the girls and young women who are under our care. You say, well, that's a pretty big, broad picture, and I accept I've just given you an enormous challenge. Let's come back a little bit closer and make the challenge a little bit less overwhelming, but still very important. Let's think about our role as gynecologists with regard to the reproductive health of younger females. You and I know, or maybe I should ask, do we know enough about what's special about the needs of young people? Do you know what they need that's different to the adult women we care for? What's special about them? Well, we know that they're in a very special developmental age when there's lots of things happening in their brain development. There's all their body changes, the pubertal changes. They go through that tension of wanting to be separate and grown up and not have anything to do with parents. And yet at the same time, they're very dependent on us. They're also very influenced by their peer group, and they're very much at the time in their life when they take risks. So if we're going to be involved in the care of younger women, then we need to be very conscious of that developmental stage and what that age means in terms of their behaviour. I will also get onto the topic of different pathology in this age group, but let's stick to risk behaviours. You can see the upper picture. We can't deny that young people are very, very, very influenced by social media. They are engaged in their social media continuously. They know stuff about social media that you and I don't know. They're also undertaking risky behaviour, which might be smoking, but it might also be alcohol, and it might also be risky sexual behaviours. What do we know about sexual behaviour? Well, we know that there's increasing rates of premarital sex occurring in Indonesia, so that the number of young women who are having sex before marriage is quite clearly increasing, with 17% of senior students having reported unsafe sex in one region of Indonesia. A survey of teenagers in a number of cities in Indonesia saying that 63% of them had had sex, and that 21% of them had had an abortion. And that the International Planned Pregnancy Federation, the PKBI for you, reports that there were at least 8 to 10 teenagers a month presenting with unplanned pregnancy. So we know that teenagers are doing risky things. On the other hand, we know that as Indonesia is extending the age at which young people are staying at school, is reflected also in the age of marriage being progressively taken a bit further along. So that an age of marriage that had been 16 was up to an age of 19. So that transition to being slightly older when women are having children reflects education. And we know that if we educate more, that we also end up with families who have a smaller number of children, but we also know that those children are also then given a better chance at education, which usually also translates into a better opportunity for employment. I understand from data from Indonesia that nevertheless 10% of couples are have a child in less than 9 months after getting married, suggesting that people are getting married for this reason. It's hard to make comparative data to Australia here because the age of marriage in Australia is 30 for females, but in fact of couples living together and often having children together, 16% of couples are actually not married. So there's a major difference there in terms of what's accepted in society. But if we look at unplanned pregnancies and abortion, the numbers in Indonesia suggest that there are a substantial number of abortions occurring, but Australia's abortions are estimated at about 100,000. Given that your population's 10 times, that means that despite the differences in our education, we still have a significant abortion rate, although it's probably half of what you have. It raises questions about what we're doing education-wise in terms of talking about sex education, in terms of providing contraception availability to teenagers, and it raises questions and challenges for you about what you're doing about sex education at school and what you could be doing about contraception access for teenagers. Australia's abortion numbers are not good. There are many parts of the world that are far, far, far better than we are. But then I can look at places like the US and say that their figures are probably worse, far worse than ours, and probably worse than yours as well. So there are challenges there that don't necessarily simply equate to how much the earning capacity of individuals is, but reflects other cultural and educational factors. So as obstetricians and gynecologists, we know about unplanned pregnancies. We see the teenagers who have the teen pregnancies. We know that abortions are happening, and we're the ones who know that abortions are happening illegally. We know that teenagers are taking risky behaviours. And again, you might say, well, that's not really my job to ensure that the education is occurring in schools. But I think we do have a place to have a voice because we are the ones who are seeing the consequences. And therefore, we need to be having a voice to our politicians and educationalists to ensure that appropriate action is being taken to try and avoid problems. We need to explain to young people that our conversations with them are confidential conversations because we know that this increases their openness. So we have a responsibility to provide confidential care to teenagers. We have a responsibility to encourage education at schools and encourage access to contraception and safe abortion. What about the special problems that happen in teenagers that are different to adult women? Well, there's no doubt that if you and I think about abnormal uterine bleeding in adult women, the causes by far would fit into the structural problems such as polyps and fibroids, whereas they're almost unheard of in teenagers. And therefore, the coin end of abnormal bleeding is where the management needs to be focused. And we need to be aware of the differences of what the problem is in a teenager versus when we're caring for adult women. We need to be very conscious that teenagers who present with period pain deserve good care so that they're not missing out on school, that they're not missing out on activities, and so that we can help them optimize their quality of life and achieve all the things that young women should be able to achieve. So, do we need specialists in this area? Well, we certainly need people who understand the differences in what pathology and what the problems are. We need to have specialists who understand the different developmental stage and their educational needs. We need gynecologists who feel comfortable to provide optimal care for teenagers. So there are opportunities for people to achieve this, and there are online webinars now occurring for paediatric and adolescent gynecology. There is a society for paediatric and adolescent gynecology in the Asia-Oceania area. There's the international organisation. There's the opportunity for observerships and training positions in a number of countries. And I challenge you to establish an Indonesian Society of Paediatric and Adolescent Gynecology so that you can expand this special area. I'd like to thank you for the opportunity to talk to you and thank you for listening. This is some of the wonderful things that I have the good fortune of having at the Children's Hospital where I work. Once again, thank you very much.
Yeah. Thank you, Professor Grover, for very nice presentation, and nice thing also to let us establish what is the pediatrician and adolescent gynecologist specialist, and then to establish in Indonesian Society of Pediatrician and Pediatric and Adolescent Gynecologist Specialists. And let us move to next presenter. I will conclude your presentation first before we move to other presenter. The first one is perspective in adolescents' reproductive health, and younger female needs specific health, and they will have greater impact for their risky behavior, such as premarital sex, smoking, or abortion. And you underline the role of ONG specialists in the area of adolescents' reproductive health, especially in confidential consultation to give optimal care or optimal management to younger female. And then the last one is the pediatric adolescent gynecologist specialist. It's a new thing for us, and we will discuss it now in the discussion session. Okay, thank you, Professor. And then move to second presenter, the distinguished Ibu Dr. Erna Mulati, MD, MSc, GMFM. She's the Director of Family Health of Ministry of Health of Indonesia. Dr. Erna will present us the current evidence in adolescents' reproductive health with underline in adolescents' health services in Indonesia, especially in COVID-19 pandemic, and then the intervention that has been done by Indonesian policymakers. Let us hear Dr. Erna Mulati presentation. Please, Dr. Erna, you have 15 minutes.
Thank you, Dr. Arietta. Ladies and gentlemen, good afternoon. Allow me to stop my video because the signal is not good, so better I stop the video. Good afternoon. This slide show to us that we have age issue among adolescent and school age children in Indonesia. about the nutrition, non-communicable disease, hygiene and sanitation, mental health, reproductive health, bullying and injuries, HIV/AIDS, and tobacco and drugs. About the nutrition and reproductive health problems in the adolescent and their associated with the later adult health and stunted born children. We have a hike of the anemia among the children. 32% at the female 15 until 24 years and 26% in the female at 5 and until 14 years. And we have also the high malnutrition, short, and also obese at the female adolescent. This is related with eating habit and lifestyle among the children, about the nutritional intake, and also the iron tablet supplementation for the adolescent girls. This slide show to us that regarding the source of knowledge of physical change during puberty, they were mostly mentioned by females and males who are teachers. Among 79% and 63% friends, and then also the internet, and only 1% of them know it from the radio. 33% of women answer correctly about the woman fertile period. 31% could not answer correctly, and 6% said they did know. Similarly, 37% of men answer correctly about a woman fertile period. 55% could not answer correctly, and another 8% said they did know. In regards to anemia, most respondents have insufficient knowledge on anemia. Anemia is perceived as a lack of blood by female and males. Only 8% of females and 3% of males can explain anemia correctly. How about the adolescent reproductive health situation? About 9 in 10 women and 86% have heard about the HIV/AIDS. The highest percentage of women and men who get information about HIV/AIDS from school and teachers. The highest percentage of female and males who know how HIV/AIDS is transmitted from mother to child is during pregnancy, and 76% and 30% respectively. The percentage of female with comprehensive knowledge of HIV/AIDS increased from 13% in 2012 to 60% to 2017. About the adolescent reproductive health situation, the knowledge and preference on reproductive health discussion spots mostly to the Puskesmas PKPR, to the primary health center who give the health services to the adolescent. Adolescents first receive reproductive health information at school, mostly about the physical change during puberty, some about the contraception and HIV/AIDS. The information mostly from the health personnel, and also from the mother and the teacher. How about the adolescent reproductive health situation? Majority of females or 80% and males 84% been dating and started dating at 15 and 17 years old. This slide also show to us when they have the first sex. For the woman in the 15 until 19 years old, 59%, and for the men 74%. And the unwanted pregnancy about the woman in the rural area 16% and 9% in the cities, and in Indonesia 12%. This slide also show to us the teenagers pregnancy, so that the reproductive health is one of the priority issue among adolescents, which needs particular management. The massive access to internet provide both positive and negative impact. The Ministry of Education and Culture research in 2017 found 94% of adolescents being exposed to pornography. Even some of them have been exposed in elementary school, either accidentally by purpose. If we look at the state of growth and development, adolescent is the period of fasting brain development that expose adolescent to vulnerability of diverse risky behavior. So it is crucial to empower adolescents with appropriate knowledge and skill. However, the provision of the health information, including reproductive health provided in school, is still lacking. Based on the Global School Health Survey in 2050, only 36% of the teenagers have ever been taught how to refuse when someone asks for sex. Moreover, sex among adolescents may result in adolescent pregnancy, which may lead to dropping out of school, gloomy future, higher adolescent maternal death as well as their infant deaths, increased stunted born children, and increase on the risk of getting HIV/AIDS, sexually transmitted disease, and cervical cancer. This slide also to us that the first married at the female, they start at 10 until 14 years old, about 4.8%. And then 15 until 19 years old, about 41.9%. And about 92% giving birth before 20 years old. This slide also to us that the percentage of women aged 20 to 24 years old who get married before 18 years old. In Indonesia, in 2017, about 25% of the teenage 25%. And also based on the National Social Economic Survey in 2018, they are married before 19 years old. The presented in Indonesia 96.22%. We know that we know that the maturation of gestational eggs will decrease stunting and low birth weight and also the infant mortality rate. This is the determinant factor of reproductive health related with the social economic condition, geographical condition, culture perception, and also the gender inequality, discrimination, subordination, vulnerability to violence, multiple roles. How about the intervention on adolescent reproductive health and nutrition? We have 7 activities to intervention to the adolescent. The first to school health program. The second is the healthy school model, the iron tablet supplementation, adolescent friendly health services at the primary level. And also we have also the activity related with the adolescent community-based and integrated health post. And we have the reproductive health education but in the school and also the out of school, and also we have adolescent health intervention in child shelter and prison. This is the activity about the health school programs. Also, we have activity routine health literacy using health report book, or we call buku raport kesehatanku. This is from the primary, secondary, and high school. And also we have the aktivitas the aksi bergizi or the nutritional action in some pilot project in the Klaten and also in the Lombok Barat, in the Nusa Tenggara Barat. The implementing partner affection platform school community Posyandu, and also for the PKPR adolescent friendly health service, there are 6,650 puskesmas with PKPR in 2019. This is the activity of the PKPR out of the puskesmas for promotive, preventive, curative, and rehabilitative. This is for the Posyandu. Almost all in the village in Indonesia have the Posyandu Remaja or adolescent Posyandu. Also, we have the integrated reproductive health education in school. We have some material concept on adolescent reproductive health education, value, norm, culture, and self-regulation, adolescent growth and development, adolescent reproductive health problem prevention on premarital sex and child marriage, gender and violence, the role of the technology, information, communication in reproductive health education, and reproductive health support and service in school. Also, we have the prevention in child shelters, in pesantren, orphans, and also the prison. Related with the nutrition and also the health reproductive, and also about the hygiene sanitation. This is the health policy on the adolescent reproductive health. We have Act number, we have some act and also the government regulation, also for the minister regulation, and also some activities that the central government give to the province and also to the puskesmas, the primary health centers, to support the reproductive health in the community level. This is the minimum initial service package for the reproductive. Their main objective for the objective fund for the ensure the health sector, cluster, and sexual violence, and also the prevent to transmission and reduce the morbidity and mortality, and also the the comprehensive reproductive health services, and then there are 3 priority activities in addition: continue contraception, adolescent reproductive health, and also the reproductive health logistic support such as reproductive health 10 individual kits and also midwifery kits. This is the adolescent health services in pandemic COVID-19. I think we have some same in the some area. We have some problems, and also we have almost 8% of the total positive confirmed case of the children aged 6 until 18 years for the COVID-19 in 80 October 2020. About 28,009, almost 29,000 of the population who get the COVID. This is the health service for school age and adolescent in pandemic area. In pandemic COVID-19, about the adjustment of health services for the school children and adolescent in the community level, and also to improve media for the prevention, utilization of information technology for health monitoring, change modification on the environmental structure of school, and also the activities for optimizing the role of the family, health workers, school, madrasah teacher, and the community in breaking the chain of the transmission of the COVID-19 and back to school health protocol preparation. This is the adolescent education, and also this is the sorry for the education, nutrition, literacy, and also we have the activities to decrease, to improve the communication, education, and information about the pre-marriage health services. We have collaboration with the Minister of Religion to reproductive health services for the married couple, for reproductive health education, and also the health assessment. We hope that the problem that can be treated, controlled before marriage. Pre-married couple has enough time to prepare physically and mentally for married life. This is the ideal condition that we are socialize to the couple and also to the pre-married couple before they are married. Thank you very much.
Thank you very much, Dr. Erna. So many new information about the adolescent reproductive health in Indonesia, especially what intervention has been done for the adolescent reproductive health. And the main thing that the rate of teenage pregnancy and child marriages has always higher and higher every year. And then we have done so many things to prevent and to do how to prevent the adolescents or teenage pregnancy and child marriage. The interesting thing is about we do have adolescent-friendly health services, and then adolescents posyandu, and then we need to get together to prevent and to educate the adolescent how to prevent the teenage pregnancy and child marriages. And now we come to the third presenter, Dr. Julianto Wicaksono. Yeah. Slide, please. Dr. Julianto Wicaksono is a teaching staff of Indonesia University Hospital and the lecturer of Department of OBGYN, Faculty of Medicine, University of Indonesia, Cipto Mangunkusumo Hospital. Dr. Julianto will give us some point about current controversial issues on adolescent reproductive health in Indonesia, such as adolescent pregnancy and marriages, reproductive health care for adolescents, and contraceptive use for adolescents, and reproductive health education for adolescents. Yeah, Dr. Julianto, you can start your presentation for about 15 minutes, please.
Thank you, Dr. Arietta. Good morning, ladies and gentlemen. First of all, I would like to thanks to the OC and the HOPSI to invite me to have the presentation in this event. Yeah, issues that has been mentioned by Dr. Arietta, it will be my topic will cover in this year. As you know that nowadays in Indonesia, we have in our population, 25% of the population is the adolescent age. And then you know that the percentage of the adolescents up to the probably the next 15 years will be decreased to the around another 5%. And what will be the issues then? As you know that I'm sorry that because I'm preparing the presentation in Bahasa Indonesia for making it will be easier for the audience to follow the presentation. Yeah, you know that the reproductive or the adolescents factors that influencing by several factors like social factors, household and community factors that can build the character of the adolescents to have the attitudes in their life. Yeah, for example, how then by the background they can choose the good or the bad close friends, yeah, how to do the safety sex, and then how to spend trying to try the drugs and etc. Also including the use of the contraception, and also of all of this will be affected to the output or the outcome of the adolescent itself, yeah, the healthy or the disease kids or probably the mortality as well and all the morbidities. And as you probably aware, this for issues is to be the very not very strategic, yeah, but very controversial. Therefore, I will come to the first issues about the adolescent pregnancy and marriage. As you aware, this is the slide that I've used to when we come to the court, the constitutional court, to delaying the act or the law of marital age at the time, marital law that allowed for the women to marry on the age of 16 years. And so this I will try to confidence to make it clearly with the court that it's a very dangerous because they're not ready with the mental and emotional maturity, and also the series of various factors that probably can affect the disease morbidity and mortality as well. And but you know that it's very surprising for several for Indonesians, especially because by this research, Riskus does 2010, that the young women on the age of 8 years can have tried of free sex for the first sex for her life. Yeah, that it's increased and until the age of before 18 to figures of around 10 to 15%. This is the figures of the sexual activities in adolescents, yeah, before the 18 years, starting from the year of 8. Yeah, then you know that the risk and the consequences of the adolescents pregnancy increase, and the figures is before the 18 years it's up to 35 to 36%. So this is the figure from the for the last 5 years. And this is equally throughout the Indonesian provinces. In the right side, you can see the red bar will be the age of before age 16, and the blue line from the age of 8 to 17 to 18. So this is you see that the figures of the adolescent pregnancy is around 35 to 36% during the last 5 years, and this is equally between the 34 provinces throughout Indonesia. Next slide, please. Yeah, this is the consequences of the teenage pregnancy. Of course, the teenage marital. Yeah, then if you see here that approximately around 25% of the young population has got the marriage on the age before the 18 years. This is I think one highest in the Southeast Asia. Yeah, the figures. And you know that the figures in outside the Java Island, it will be the highest, up to almost 40%. Next slide, please. Yeah, this is actually the data of the IDHS adolescents that show you that actually the dreaming of the young boy to get married, it's at the age of beyond the 25 years, but a bit younger in the young ladies. Yeah, and you see in the blue bar show you that the maturity or delaying the marital age is successfully increased, yeah, from the 17 years 30 years ago, and nowadays around 22 years old. Yeah, next slide, please. I'm sorry. You know that this very interesting data. Yeah, you know that by the IDHS show that actually the young or the adolescents decided wants to get married by their own decided. Yeah, but you know the actual happened then. All the marital event is actually determined not by themselves. Is as they dream around 70 to 75%, but it's decided by the parents actually. So what's then the cause of it? Yeah, it is actually has been studied by the UNICEF that the factors of the social, economic, or probably poverty, the low education background, probably culture and mass media campaign, also the teenage pregnancy affecting to the decided of the parents to get the kids to have the young the marital pregnancy on the adolescence age. Next slide, please. Yeah, so this is the I will present the first controversial is about the prevalence of the adolescent pregnancy now entering the emergency situation, because the figures is around 24 to 25%. Yeah, there's even we already have the agreement by the court to delaying the marital age to year 19 is still need another 3 years to the act can be implemented. Yeah, so it's very, very important. And also we should do some investigation or probably some research why then the dreaming of the young age cannot be a reality, and why then the decision of the parents will be very powerful than the dreams. Next slide, please. Yeah, and the second issue is about reproductive health care. Yeah, probably already mentioned by Bu Erna. Talk about the Puskesmas Ramah Remaja. Yeah, right. So actually, next slide, please. Yeah, the issue is come from a lot of factors can be happen on the teenage pregnancy due to the young not experienced well with the life of the marital. They will have the kids with the several factors of the disorders like mental delaying, inadequacy of the breast fat that can be affected to the kids, to the baby's growth, and then some diseases, stunting, and etc. And also when they growing up, they can be affected to the intellectual and and the prestation in the school age, and also of course then coming to the reproductive age and becoming very uncompetitiveness with the normal marital couples. Next slide, please. Yes, next slide. Yeah, this is actually the approach of the life cycles that mentioned that with attention that at remaja and pra-remaja, a lot of then incapacity of their life in the schooling or probably in life or during the works that can be affected to the capacity of their ability in the schooling or in the work. Yeah, that's a very is due to probably the young marital married in the earlier. Next slide, please. Yeah, actually, the adolescents have probably two options. Yeah, they have the sexual active with the safe sex and with unsafe sex. Yeah, with the safe sex, of course, it will give the protection for them to have the better life in the future. But with the unsafe sex, that can be expose them to several medical and probably social and bad future life for them. Yeah, this is very important that they should know. Yeah, next slide, please. Next slide. Yeah, and also some morbidities will be also come to them with a high expectancy, high risk of the baby's abortion and fetal death. Also the risk of the preeclampsia, maternal death. Also the damage of the pelvic floor, and then also the depression. It can be come to them by having the marital marriage and also the young pregnancy. Next slide, please. Yes. Yeah, this is actually I'm taking from the literature that if the lady, the young women married before the year of the age of 19, it will giving them risk of the stunting, wasting, underweight, and infant mortality compared to the older age. Yeah, this is very important data that probably can give the education to the parents why it's important to delaying the marital age or marital pregnancy to saving the kids and also the babies that they have. Next slide, please. And also the maternal deaths. Next slide, please. Also having the high risk evidence during the very young age, before between 15 to 19 years compared to the elder. The lowest figures is between 20 to 34 years. That's why then we call it the reproductive health age will be better to have the pregnancy or probably the medical beyond the age of 20 years. Next year, please. Yeah, we have in BKKBN we have that program to accompany the young couples before the marital and during the pregnancy and after they have the kids and during the parents having the adults and kids to embedded program that to preparing them to facing the life. Yeah. This actually the program is built in the BKKBN program. Yes, slide. I'm sorry, yeah, because it's the time will be a bit delayed. Yeah. Yeah, we have the Kampung KB, that's the family planning villages. The figures in 2018 now are already 15,000 compared to in this slide around 7,600. And Kampung KB is actually the place that all the couples with reproductive age and also especially the adolescents age to have the activities and they can enrich the knowledge and the capacity and this area. Yeah, it's very good program done by the BKKBN at the moment. Slide. Actually, it is this the next slide will tell you about what will be the activities in the Kampung KB. Yeah, they equipped with some program with we call BKB, BKR, BKL, yeah, and then UPPKS, and also the consultating center for reproductive and especially the students. Next slide, please. And this is the activity. Next, just next, please. Okay, just this is the activities. Yeah, I'm sorry because of the time. Next slide, please. Yeah, because it's a bit delay with the time. Moving slide. Yeah, and it's covered only, you know, in it's not a bit change figures in 2019 around 20,000 peak KR facilities, and this is only covered around 10% of our school program in Indonesia. There's a very low, actually very low figures. Yeah, paid by the covered by the budget of the government. Yeah, next slide, please. Next slide, please. Next slide, please. Yes, next. I'm sorry, I will cover because to move to the next slide will be takes such time. Yeah, this is actually it's already mentioned by Bu Erna talk about the KPKR. Yeah, next slide, please. It's already presented by Bu Erna.
I give you 5 minutes extra, Doctor.
Okay.
It's okay.
Yeah, okay. This is actually standard. This is the new standard actually given by the government. This slide, yeah. Actually, because the new president, President Jokowi, has launching the national medium-term program for the year 2020 to 2024, and followed by the ministerial and also the lembaga, what's that, the board, yeah, that to follow what should be followed by the program of the president, and also in the level of the province and of the cities of district, also they develop also the program. But you know, if you can, if you probably have such a time to follow the program, this the program in the level of the province and kabupaten usually not following well what has been decided by the president in the RPJMN program. For the example, for in the term of the adolescence program, it's not mentioned sometimes or very limited or only one words in the program RPJMD in the level of the province. I mean, it is very important, yeah, because in the era of decentralization, the program is not necessary follow the program of the president. But you know, I mean, that's the task of the HOPSI to follow the to be wants to know what then happened on the level of the province or district if he wants to probably to make it a better life for the adolescents. Yeah? If not, it will not having the program in the level of the district or the province. Yeah. Yeah. Next slide, please. This is for next slide, please. Yeah, this is actually we already preparing the guidance for the actually if your HOPSI wants to follow this guidance, how that we can preparing well about the family planning and also the embedded adolescents activities to preparing the reproductive health activities. Yeah, this is very it's actually right-based family planning strategy also included for the adolescent activities as well. Yeah, it's done in 2017. Yeah, okay. Yeah, next slide, please. Will be next slide, please. So this oh yeah. So that's the previous slide mentioned that that's very important then for the government to improve the reproductive health care adolescents to make it harmonization and the synergy activity between the central office and the district and the government and in the province level. Yeah, and we next come to the use of the contraception for adolescents. Next slide, please. This very controversial. Yeah, for next slide, please. The first slide. The first slide, please. Yeah, because the acts and the regulation. No, previous. The regulations told. Next slide, please. This the regulation Act number 20. Can come to the previous slide. Previous slide, please. Yeah, this is mentioned that by the Act Undang-Undang 52, it's mentioned that the family planning program is only allowed by the couples, the marital couples, cannot be used for the every single woman or probably the adolescents. That is very important, and also the regulation, government regulation number 61 2014, also strengthen the issues that is only allowed by the marital couple. These are very risky and very controversial because you know that as I already mentioned that probably the problem of the sexual activities between adolescents is becoming increased, and the risk of the couple having kids in the young age is very increased. This slide, next slide please, can show you that's how much that the women age of 15 to 19 having kids until 4, already 4 kids on the age of 19. So that's mean that the ASFR, the age-specific fertility rate of the 15-19 will be 4 then. Yeah, then it will be increased than the ASFR rates age in the age of 15 to 19. Next slide, please. That's happen in the cities and in the urban area, rural and urban area. And this is actually show you that as mentioned by Sonia, that also the same, the trend of the having sex before marital is increased in Indonesia. It's a figure now around 17% now. Yeah, between ladies and increase in the women's. Next slide, please. Next slide, please. Yeah, I will skip this because this in overseas, about how they can accept the contraception between teenagers in Indonesia. Next slide, please. Yes. Next slide, please. Yeah. Next slide, please. Okay, this actually the knowledge of the family planning between teenagers, in Indonesia. You know that they already know about the family planning, and we don't know where they come from. They probably read from the internet, probably hearing from the friends, and actually what they say in the right side, it mentioned that around 70 they expecting that they can as a single, they can come to the health facilities to asking about the getting information and counseling on the family planning. It's actually the demand of the need of the young or probably young adolescents age in Indonesia. Next slide, between men and women. Next slide, please. Yeah, it is. As I mentioned, the ISFR 15-19 is very high in Indonesia. The figures, the best figures targeted by the SDGs is around 18, 10 to 18, 12. I mean, yeah. It's still 36. 36. That means that between 100, between 1,000 women, they have 36 women on age 15 to 19 having kids. Yeah, that's the mention. It's a very high figures. This is actually will increase the rate of the chance of the TFR, increased TFR in Indonesia. Yeah, the target will be the 18 in the next 5 years. Next slide, please. Next slide, please. Yeah, I will ask the Oxy to look at the data of the Susanas. Yeah, this Susanas will give you the very good data on the figures of the ASFR age-specific fertility rate on 15 to 19. That mentioned in some figures, you see that's in the province of East Java, it's still high figure up to 71% in Trenggalek, you see. Yeah, that's a very high figures because the target will be at the moment the figures 36, and the target in the next 5 years around 18 or 10 in 2030 at the end of the SDGs. Next slide, please. And this also the figures in Maluku. Next slide, please. Sulawesi Selatan also high figures in 15-19. It is in Papua. You see that beyond the 100, 116 or 130. It's 158, and it's very high. In Maluku, it's very good. In 15-19, can be reached lows down to the 12 in the Kota Tua. Next slide. Yeah, it affecting to the TFR profile in the province or in the city or district. You can also get the data in the Susnas if you want to look at the how we can make plan to the RPJMD figures in the new Bupati or new mayor.
Yeah, 2 minutes more,
Yeah,
Doctor.
next slide. Okay. Okay then, next slide. Lama banget sih. Sorry, this is not working, but this mentioned, this is very important figures. You know that how the readiness of the health facilities to accept the adolescents couple to have the health care, yeah, the adolescent care. You know that this is the figures mentioned by actually by the slide from the previous minister Bu Nilamuluk mentioned that the doctors having the competency to give a proper primary care is only around 12%. Yeah, that means that in insufficiency competency having owned by the medical doctors in Indonesia, especially the young doctors. Yeah, next slide, please. Next slide, please. Yeah, this actually that's activities done by Bu Erna. You mentioned that actually the capacity of the young doctor to have experience to insert to do the family planning service is very low. Yeah, the rate mentioned that around 78 to 88 they don't have the experience before the course. We did the course during the last 2 months to improve the capacity of the young doctor for this IUD implant and also the use of the pills. Next slide, please. Okay, and next slide, please. Actually, yeah, I'm sorry. Yeah. So the controversial issue that actually we should embed the capacity of the young doctor to be allowed, and also the role of the organization like HOGI or POGI to empower the plan of the district level on the health plan, especially the adolescents program in their medium-term planning in the next 5 years. Yeah. Next slide. I think the last. So the last about sexual education. Can you just a bit slow? Yeah, just pass the slide. Yeah, I just want to show you the next slide, please. Just until end. Can you? Yeah, trust. Yes. Can follow? Yes. Next. Yes. Okay. So actually, in this session, I will show you that actually UNESCO already published the very good models to empower the teachers and also the public figures, or probably the regulator to be competent to speak about the adolescent and how to treat the adolescents. It's very good, but it's not. It's very hard because it's back on the term of the sexual education, and sexual education is very tricky in Indonesia, and it cannot be allowed by the government also to run the sexual education in the schooling of Indonesia. Yeah, I think that I'm sorry about the very time discovering that about this. Yeah. So by my conclusion, health reproduction is still the very big issues in Indonesia, especially on the regulation and this coordination between all level ministerial organization, including the private sectors, and also about the controversial of the marital counseling in the adolescents, and also the all varieties of the health services, including the sex education, also should be discussed very deeply between all stakeholders to help the young adolescent to cover the problem. Thank you.
Yeah. Thank you very much, Dr. Julianto, and thank you very much also for other presenter, Prof. Sonia Grover and Dr. Erna Mulati. Yeah, since we only have, unfortunately, we have 10 minutes to discuss, so we can start the discussion. To open this discussion, we will start with Dr. Suryo's question to Professor Grover. According to this COVID-19 pandemic, is there any specific strategy implementation for adolescents in your country? In Indonesia, we still have a possible increased risk of unsafe sex, risky behaviors, early marriages, and then malnutrition, and even decrease of antenatal care. Can you suggest or share some ideas? Or is there any contraception counseling should be forced, quote unquote, forced as a priority alternative? Please, Professor Sonia.
So, first of all, in Australia, we've been very fortunate that although Melbourne has had a bit of COVID, the maximum number of cases we've had has been very low. So COVID has not had an enormous impact on most of Australia in terms of healthcare for adolescents. In Melbourne, where there were most cases where I live, we've had a lockdown. And so young people, we've been very limited in our movement, which means the young people have not been able to go and see their boyfriends. So people have not been going to school. So there've been a whole range of, now that doesn't mean there haven't been problems. We've had significant problems with mental health because people have been locked down. So we haven't had to put special strategies in place. And I'm not aware that we've had a dramatic change in unplanned pregnancies as a consequence. So I'm not really in a position to give you any insight or ideas because we've not had to do that. Abortion services have certainly continued. So if I think about services, lots of elective surgery was cancelled, but obviously abortion services were considered, you can't wait, you can't delay. So abortions continued to be provided. Somebody else had asked me a question about what the abortion laws are like in Australia. The laws in different parts of Australia are a little bit different, and it does depend on which clinicians, whether there are clinicians providing the services, so that you can live in a country town in parts of Australia where it's a very Catholic town, and therefore it is very difficult to get an abortion and you have to travel hours. Or Tasmania as an island mostly has to come to Melbourne. Now, things have changed a little bit with medical abortion because that's now available.
Thank you, Sonia. Or maybe Dr. Erna has some opinion about the abortion policy in Indonesia compared to abortion policy in Australia. It just surprised me that abortion rate in Indonesia is much higher than Australia, 43/100, and in ratio, of course, and in Australia is 30/100.
Thank you, Dr. Arita. The regulation in Indonesia, the abortion can be allowed by if they have a rape victim or in the medical education. Only
Emergency medical situation, right?
Medical situation. Just only two. And then, but we are now still make the ministry degree and also the guideline for these activities.
And thank you, Dr. Erna. And then there's about 2 or 3 similar questions also about abortion, especially abortion in adolescents. And the question is for Professor Grover. is there any suggestion about cultural or situational, socio-cultural and religious approach in Indonesia? Maybe some suggestion.
My suspicion is that you face similar problems, although the religion that is the religion that poses the challenges for you is different for us here, because Catholicism would be probably a bigger problem.
Yeah.
For us, it is interesting if you look at young people who choose to have an abortion versus young people who choose to go through with the pregnancy. And the people who choose to have an abortion are young people who see themselves as having a future with an education and can see themselves continuing in an education. Whereas people who are younger people who are in the setting where they are already on the fringes of education, they are not really enjoying, they cannot imagine themselves extending their education, and therefore they, having a baby is, well, at least I can be a mother, because they haven't got any ideas, because they're not engaged in education. So engagement in education is critically important. If we look at our country areas where they see less hope for education, or the education systems are not as engaging, and there's no employment, then they will have a baby.
Yeah. So the education is the most important thing, especially the education about adolescent reproductive health from pediatric and adolescent gynecology specialist. And then for Dr. Julianto, there's a controversies about contraception in adolescents. As this country policy said that contraception is only for the married person, but as we know, we need to give contraception for the teenage pregnancy or teenage for adolescents who had already, like just say, 4 babies or 4 children in the 19 years of age. And what is your opinion about the policy in contraception in Indonesia, and the readiness of Indonesian doctors to do any method of contraception in accordance to the recent research about the readiness of Indonesian doctors to do any methods of contraception? Dr. Julianto, please.
Yeah, thank you. The first step about actually that we can still give the contraception in the young women if they have the marital engagement. Yeah, if they single, that's a problem. But actually, that's if you look at in the field, that actually it's only the regulation is only for the program or the family planning given if they follow the government program. So you know that then they come to the private sectors then. So for example, they come to the white known about the PKBI and etc. They can come to the private sectors then to have the family planning method by the young family. That's I mean my answer. And the second one about about
readiness,
the
readiness of Indonesian doctor.
Yeah, actually, the readiness of Indonesian doctor is very low capacity. That's we conducting actually run by the Ministry of Health to improve the capacity of the young doctors in the young medical doctors here to have the competency of family planning. It's very good. And by the survey, yes, they right. They realize that they need that training because they not feel that feel well to run the services for the clients.
All right then. Thank you, Dr. Julianto.
Thank you.
Unfortunately, we have to finish this lively
Sorry,
discussion, because the limitation of time. Thank you very much for Professor Grover, for Dr. Erna Mulati, and then Dr. Julianto Wicaksono, and for all the participants of this discussion. Thank you very much for your enthusiasm and for your question. We have about 15 questions here. Sorry, we didn't have enough time to answer that, but we try to answer that by mail or by email. The organizing committee will do to answer the question. Thank you very much, everybody. Hope this session is fruitful and will be useful for all of us. Thank you.
Thank you, Dr. Arita.
Thank you.
Thank you for Professor
everybody.
Grover,
Bye.
and also
Bye-bye.
Dr. Yulianto.
Sonia, Dr. Rena, thank you.
Bye-bye.
Dr. Arieta, bye.
Yeah, thank you
Bye-bye.
very much. Bye-bye.
Ladies and gentlemen, now we've come to our third and last session, the debate session. We will discuss about sharp curettage versus manual vacuum aspiration, pros and cons, who will be led by our chairperson, Dr. Ratnasari Dwi Cahyanti, Magister of Medical Science, SPOG Consultant. Next, I'll read the CV of the chairperson. Dr. Ratna finished her study as Social Obstetric and Gynecology Consultant in Faculty of Medicine, Universitas Gadjah Mada, and then she also took education in Erasmus MC University Medical Center, Rotterdam, and also took monitoring and evaluation in health environment, KIT, Royal Tropical Institute, Amsterdam. To Dr. Ratna, the time is yours.
Thank you, Dr. Yoga. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, the professor, doctor, and all the colleagues of obstetric and gynecologists in this afternoon session. Today, we have a debate session where we will discuss about pro and contra in the utility of sharp curettage versus manual vacuum aspiration in obstetric practice. In this session, we will invite two resources person that they have extensive experience in the reasons about this issue, and then they also have an effort to promote the abortion care program. I will introduce the first resources person, Prof. Alison B. Alderman. For the committee, can you present? Okay. The Professor Alison P. Alderman, MD, MPH. Right now, her position is the Professor of OBGYN in Oregon Health and Science University, Portland. And then she graduate medical degree on Oregon Health and Science University. And then she took a fellow in 2003 in Family Planning, Oregon Health and Science University. And then she received also a Master of Public Health degree in University of Washington, Seattle in 2003. Professor Alison B. Alderman, she will present about the effects and disadvantages of manual vacuum aspiration for uterine evacuation. And then our second resources person is Dr. G.M. Seno, IG Specialist Obstetric and Gynecology Consultant. Right now, his position is as staff at Social Obstetric and Gynecology Division, Obstetric and Gynecology Department, Medical Faculty University Indonesia, Cipto Mangunkusumo Hospital. He graduated in 1997, obstetric and gynecology specialist at the Medical Faculty University of Indonesia. And then in 2003, she received a consultant in social obstetric and gynecology. And then he received a PhD degree in 2014 from Medical Faculty University Indonesia. He will present the cons about the role of manual vacuum aspiration in essential obstetric care. For each resources presenter in here, they will present about the pro from Prof. Ellison and cons from Dr. Seno Aji. Each resources present, they will present 20 minutes for the presentation. For the press presentation, our resources person, Prof. Ellison B. Alderman, is the time for yours.
Great, thank you. Is it okay to share the screen? Yeah. Well, thank you so much. Hopefully you can all hear me. It's a pleasure to be with you today, this evening for me. Thank you so much for being with me. Let's see here. Can you guys see the screen okay? Hopefully.
Yes, it's clear. Prof. Ellison.
Yes, good, Prof.
Yeah, it's okay?
Okay.
Great. So I'm going to be talking to you today about MVA for uterine evacuation, and I will be talking about some of the advantages and disadvantages. I just want to disclose that I don't have any special funding for this topic. And even though IPAS originally was involved in bringing the MVA to market, it's no longer directly involved with manufacturing or marketing. And that's now involved with DKT, so not involved at all. I do want to point out that dilatation and curettage, or sharp curettage, is considered an obsolete method of surgical abortion or post-abortion care and should be replaced by vacuum aspiration or medical methods. And that is a statement by the WHO. Sharp curettage is known to increase blood loss, pain, procedure time in some instances, and long-term complications like Asherman's. And that's why the WHO has decided to support the recommendation for vacuum aspiration. And you'll see here that the other organizations, including IPAS, but also FIGO, also support this statement as well. So in regard to safe uterine evacuation methods, and when we talk about uterine evacuation methods, we're talking about post-abortion care, but also indicated and induced abortion as well. And the recommended methods for providing uterine evacuation before 13 weeks uterine size is vacuum aspiration, either electric or manual, and then medical methods. And the medical methods are misoprostol based. So in some countries that may be misoprostol only, and in other countries, it may be a combination regimen or a misoprostol only regimen, depending on the indication for care. For at or after 13 weeks, so more in the second trimester, vacuum aspiration methods are also used, but sometimes with specialized forceps, and that's called dilatation and evacuation. And then also medical methods that are misoprostol based are also used. So let's talk a little bit more about vacuum aspiration, since that's the focus of the talk today. So the manual vacuum aspiration, or MVA plus, and it's still labeled IPAS since IPAS brought it to market originally, is a latex-free instrument. It has a minimum vacuum of 558 millimeters of mercury. The vacuum can be maintained for 30 minutes. It can be used for multiple times. The company will say a minimum of 25 times, but we do have providers that have said that they can use it many more times than this if it's maintained well. And it's able to withstand hot or cold processing methods, so autoclave or chemical sterilization methods. So all of these things are a real positive in that it can be used multiple times and it has the vacuum needed to remove products from the uterus. Now, one of the downsides anytime we introduce something new is that people have to get used to a new system. And one of the downsides to the MVA is that it has parts to it, unlike a sharp curette, which is just one metal instrument. And so there are a number of parts, but it's very easy to take apart and put back together. However, people need to know what parts are there and how to handle them in a way that will maintain the instrument and keep it working for a long period of time. One of the other downsides, anytime you have an instrument that can't be used forever, like something that's metal, is just ensuring a sustainable supply. And so this can be problematic sometimes in different systems. However, there are all sorts of things in medical care that we have to have a sustainable supply. So for this in particular, this can be just added to the other sustainable supply things that we need to put into place. The other thing that's nice about this is it's not a one-time use item. It can be used multiple times if maintained well. The one thing that's important to do, and we've had country programs that have made this mistake before, is that DKT has multiple types of manual vacuum aspirators. They all work very well, but some of them are used for one time and they're meant to be disposable. So one-time use, don't clean them, and they're meant to be thrown away. Some are the one like the MBA Plus, which can be used multiple times. So it's important when you're ordering to make sure that you know what you're ordering. And when there are multiple things to order, sometimes that gets confusing. As well, what also can be ordered and sometimes is not when an MBA is used is the dilators, because for some instances, like missed abortion, it's important that you have the ability to dilate the cervix. And these dilators in particular work very well for pregnancy care with post-abortion or missed abortion because they're very tapered, and so they go into the uterus and the cervix very well, versus the Hagar dilators, which you have to put more pressure to get them to pass through the cervix. One of the other things that's been found is because manual vacuum aspiration and vacuum aspiration can be done in the outpatient setting without the need for general anesthesia, it's incredibly cost effective. So this is a real positive. And in a number of countries, this has been shown to be true. And so comparing that you need to do a sharp curettage in the operating room versus a manual vacuum aspirator that you can do really anywhere, it ends up being very cost savings for the whole system. Another positive is the safety record that vacuum aspiration has, which is one of the reasons why the WHO also supports the recommendation of switching to vacuum aspiration. And because this is now the standard of care, really, further studies really globally can no longer be done. And so the retrospective case series of 80,000 women that looked at vacuum aspiration versus sharp curettage showed that there were more major and minor complications with sharp curettage. And then another case series of 100,000 women in Japan also showed a similar situation with a much higher rate of complications, including incomplete abortion with sharp curettage. The other thing that we can see is Asherman syndrome, and Asherman syndrome has an increased risk with sharp curettage. In one study, the incidence was 1.2% with sharp curettage and not at all found with MVA or medical management. The difficulty with determining something rare like Asherman syndrome is a very large study is needed to demonstrate these really rare differences in risks. And in large populations, this rare risk can be very important, but overall, it's difficult to study because of the large numbers needed. And again, now that the recommendation by the WHO is to move forward with introducing MBA and making sharp curettage obsolete, really globally, we can no longer perform these head-to-head studies. There is a Cochrane review on surgical procedures for evacuating incomplete miscarriage, and they found that vacuum aspiration is safe, quick, and less painful than sharp curettage. You can see here that there were some similarities between the two methods, but overall, vacuum aspiration continues to be the method that appears safest. What's also interesting with manual vacuum aspiration is that there's task sharing that can be done. So we know that sharp curettage has been a method that has been used by OBGYNs or specialists in the operating room. Manual vacuum aspiration can be very safely performed by a number of levels of healthcare providers in the healthcare system after training and proctoring. And you can see here that the green checks and the green circles show that, in fact, nurses, midwives, non-specialty doctors can provide these services safely. So for task sharing or shifting or collaboration that occurs within a health system, expansion of services can occur because these techniques can be used safely by different cadres of providers, which is a real positive. What's interesting is around Asia, task sharing of post-abortion care is pretty widespread. And you can see here with different countries in Asia, including Nepal, Bangladesh, and India, that different cadres of providers are performing manual vacuum aspiration after training and support for safe services. Nepal's program is long-standing. They have a lot of information around the safety of different cadres of providers performing these procedures, and Bangladesh does too as well. One of the other things that's a real positive with manual vacuum aspiration is the pain management issue. Now, pain management is an essential component of care, no matter if this is done medically or by vacuum aspiration. And really the balance or the choice around pain management is the patient's choice, safety of the method, and the resources available to make it safe, and the type of medications available. But according to the WHO, general anesthesia is actually not recommended on a routine basis because it increases costs. There's an associated higher rate of hemorrhage with post-abortion care and the use of general anesthesia. General anesthesia is associated with higher risk generally. Again, there are specific instances where women or difficult cases or concerns may make it so that you need to use general anesthesia, but routinely it's not recommended. The recommendation for pain management really in the outpatient is to use a paracervical block and non-steroidal anti-inflammatory, plus non-pharmacological adjuncts like support, heat, or ice, depending on the culture. Sometimes additional oral medications or IM medications are used depending on the health system, what's available, and what's desired. So overall, the positives really of manual vacuum aspiration outweigh the negatives. It's extremely safe. Major complications are less than 1%. It's highly effective, 98 to 100%. It's less costly as it can be performed as an outpatient. General anesthesia is not recommended or routinely necessary with a manual vacuum aspiration. And acceptability is extremely high with women having had this procedure. One of the positives and the negatives about introducing a new technology is change. Change is difficult. It's always hard to adapt to a new skill, a new equipment. And so that can be something that in a health system, it's difficult to adopt. The positive, though, is as we move forward and we find new and improved ways to perform medicine and to provide procedures, that just improves the care of women. And Also, by learning a new skill, it also provides a mental health benefit to providers too as well. I oftentimes talk to people about the fact that, you know, for many years, many people don't wear a helmet with motor vehicles and riding a motorcycle or a moped. They've done it safely for many years. They've never had any problem, but it just takes that one time to have the accident. And we all know that wearing a helmet is actually safer. So it's kind of making that change that makes it so difficult. And when we introduce these services, it can be really difficult to adopt just because of the change behavior that it takes to adopt new skills. But manual vacuum aspiration is actually incredibly easy, fast, and with a minor amount of training, really a large number of people can learn how to do it safely. So I'll end there, which I think probably means that I can add a little bit of time back to the discussion and to the next presentation. But I thank you for your attention, and I hope I am making sense since it's midnight here and past my bedtime. But I'm enjoying being here, and I thank you so much for inviting me.
Thank you so much, Prof. Alison Edgerman. In the middle of the night, it is the first time for you to present in this annual meeting. Yeah, but likely your presentation is very nice and very clear for us. It's likely open up our mind for the next discussion. Okay, and then the second presentation, our resources person, Dr. J.M. Seno Aji, Specialist Obstetric Gynecology Consultant. He will present about the contra in here, the role of manual vacuum aspiration in essential obstetric care. Please, Dr. Seno, you can present your presentation.
Okay, thank you, Dr. Ratna. So I'll present the role of MVA in essential obstetric care in Indonesia, especially Indonesia. So next slide. As we know, in certain countries, it's about 50% of maternal mortality rate is due to abortion with risk, and according to WHO, mortality rates is about 15%, and estimated 20 million unsafe abortion per year, and 700,000 maternal deaths due to unsafe abortions per year, and 1 of 8 maternal deaths are due to abortion with risk. So next slide. Okay, we can see that according to tables, this is especially in Asia, and Indonesia is still in one of the countries, especially in Southeast Asia, still have a problem with amount of abortion with risk. So I think this is very important problems in the world. So I think that this is important point. Next slide, please. Okay, in Indonesia, we have a post-abortion care policy and strategies. According to Directory of Kesehatan Keluarga, it means that's the health of a family. So they have a situation analysis that the maternal death determinant analysis according to Litbangkes. This is some of a government for research, that we have 7.2% of maternal death occurs in less 20 weeks. It's about 1,000 miscarriage cases. So we know that this is all the maternal death causes. This is one of them is caused by hemorrhage. Is the abortion is one of hemorrhage problem is caused in maternal death in the world. So I think this is very important problems. Next slide, please. And we see this is post-abortion care methods. The abortions management using MVA or EVA, we say that's EVA, electric vacuum aspirations, is significantly less than traditional curettage. We say that's dilatation and curettage. The US Maternal Hospital, we have 4 types of hospital in Indonesia. Type A is the best, type B, type C, and type D. Okay, next slide. Especially in Java, Java is crowded island in Indonesia, so hospital capability in Java and the post-abortion care, we see that this abortion management with MVA or AVA, which is safer than Curetes, I agree that's available only in 65 of presentation healthcare facilities. So that is a situation in Indonesia. Next slide. And some assessment need further evaluation to strengthen post-abortion care, especially in reducing maternal mortality rate in Indonesia, such as availability of post-abortion care is limited and centralized in hospital, while BPJS is an insurance provider health in post-abortion care in the first facility through non-capitating funding. And to almost all the post-abortion care in Indonesia are still using short curettage, and MVS rarely used. Next slide. And had recommended the using of vacuum aspiration to remove conception renum, to stop using sharp curettage. But we still have problem with how do we get the manual vacuum aspirations. It's are not commonly found and not even available in e-catalog in Indonesia. So it is the problem. This is one of our problems. Next slide, please. Okay, in element of post-abortion care program, we have three part. First part is incomplete abortion, emergency, and complication care. Second part in counseling and post-abortion contraception care. We know that every abortion or every curettage we connecting with contraception, because we have to maintain the capability or the health of the mother who get abortions. And third is building relationship with reproductive health system. Next slide, please. And we have problem in delay in post-abortion contraception care are due to lack of staff knowledge and lack of reproductive health services, especially for certain community groups, and lack of cooperation in post-abortion care with family planning clinics, lack of understanding of safe and effective post-abortion contraceptive, and lack of information on pregnancy miscarriage contraceptions. Next. And we see that this MV and curettage still have complications and the increasing of complications connecting with the increasing of the age of pregnancy. But we can see this MV is still better than curettage. Next. According to Biran Afandi research, then we found that so four complications: hemorrhage, infection, lesions, perforations. But still, we notice FEM is better than DNC. Problems are, yes, next slide, please. Sometimes we face the patient with complications in the conditions like shocks, heavy bleeding, infections, or intra-abdominal trauma. It seems that we cannot use MV in the situations. Okay, for technical problems, sometimes we face with the MVA tubes, full MVA tubes. Sometimes cannula detached before evacuation process done, clog the cannula, or failure develop negative pressure in MVA tubes. So in this situation, maybe we need more than one MVA equipment, or we have to give more training for the provider who do this, because this is very important to make the quality of the MVS good. Next. And procedural problems. Sometimes we found too little tissues or not complete evacuations. Sometimes faced with tissue mass has been expelled before MVA process is done. So in this situation, we have to make a diagnosis by ultrasound. So we need ultrasound for these conditions. Okay, another problems. Okay, another problem is bleeding sore is not come from pregnancy and ectopic pregnancy. I think ectopic pregnancy is interesting because some of the symptoms of ectopic, just like incomplete abortions, pregnancy, bleeding, or some kind of pain. So it's just that we have to make work diagnosis system is probably of ectopic pregnancy. Post-abortion syndrome and neurogenic shocks. I think this is one of the problems, both of curetage and MVA. Next slide. Other complications, I think, uterine perforations, the cervical lacerations, some with shock and heavy bleeding, and post-operative infection or embolism because of the procedure, because we connecting with some kind of pressure of MVA procedure. Next slide, please. I think this is an interesting point for pain management. So we know this is MVA use paracervical block. It means that this is local anesthesia. I think this is a client have a dependent on her pain threshold. In our experience, this is most of the cases still feel some pain and uncomfortable. So this is a problem, and this might have a serious outcome for pain management. Next slide, please. Okay, for maintaining the quality of post-abortion care programs is important too, because we have a problem with that. First is quality problem, access the first level of services. You know that is if we do with MVA, I think it's not only OBGYN do or medical doctors, but maybe a nurse or midwife too, the MVA. So I think this we have to maintain the quality of the health providers. And locality would case many disadvantages, and the systematic improvement, it is a critical component to maintaining the quality of post-abortion care program in Indonesia. And some kind of problem occur due to gaps of reality and expectations of the clients. And there are benchmark of assessing the quality improvements. Okay, next slide, please. Okay, we until the end of my presentation is the conclusions. We know this. The first, in general, it's necessary to treat incomplete abortion properly. I do agree. We do agree. So MVS had advantage in terms of time and cost, or maybe the safer the procedures. Okay. And third is because of without general anesthesia procedure and perform in operating theaters, I think it's my private opinion that MVA has several weaknesses, such as it's difficult to do in a complicated patients. The client often feels discomfort because it's performed without general anesthesia, and this is quite important based on our experience and research. Next slide. And fourth, inadequate of the availability and adequate of storage is possibly sterilization of methods. We noticed some of the MVA made by some like a plastic. So we know that this plastic, some our experience is problem with how do we sterilize the plastic, because some of plastic being broke after give out situation. So it is sometimes we have any difficulty for this. And fifth, this is client perspective. It's difficult to work on, especially for educated and well-informed client. I think it's middle class of client, because they have a different perspective for how concerned about the quality of procedures, especially for safety and comfort. And six, MVA, I think it's good potentials. Is it for limiting resources or limiting setting? Therefore, the big hospital, I think since we have maybe have special treatment for this for MVA, because it's not all the patient can receive that procedure. Next slide, please. Second is difficult to maintain the health provider quality. So that because this is so many kind of quality provider, so they have to meet the difficulty of how to make this they do properly. So and last but not least, as MVA instruments are not commonly found, and it's not available in national international standard, GCR ISO standard. I think this is our homework to make this procedure go in that standard. Okay, that is my last presentation. Thank you very much for your attentions.
Thank you, Dr. Seno Aji, for a great presentation about the cons and the FEM program. Okay, right now we will discuss further about pro and contra in the use of FEM in the obstetric practice. Until right now, is there any question? Okay. And then I would like a comment from Prof. Ellison and Dr. Seno. What of you do you agree with the use of FEM in this case, particularly in Indonesia?
Well, I can't speak for Indonesians, but it sounds like, you know, when I come to talk to different countries and help introduction of safe services, you know, the concerns that you have are very similar, and we've been able to safely introduce MBA into really all over the world. And then people slowly adopt it as their method of choice. It sounds like Dr. Seno and I actually agree on a lot of things. There are very few things that we disagree on, and I think it sounds like most of the things that we agree on are safety and how well it works, its efficacy. I think in regard to pain management in a society and in a culture where you've been using general anesthesia for a very long time, it's hard to think about adopting less pain management. And I think that's where choice comes in for patients. There are some patients that may not want to go to sleep. They want to have more control. And there are other patients that may want to go to sleep. And I think depending on what level you introduce the care into, there may be safer instances where the choice for general anesthesia or moderate sedation are available, and other places where maybe it's not. In my own setting, we provide a continuum of care for pain management. So we always provide pain management, no matter what, but we talk to the patient and we assess their indication for care and their medical management to see what range of pain management they might need. And because we have safe services available for pain management, we're able to really meet the needs of the woman. But it's only a very small percentage that actually end up having general anesthesia. The majority either decide that they want more paracervical block with medications, or they decide they want what we call moderate sedation. So they're still breathing for themselves, but they might be a little sleepier. And so we have kind of the full continuum of care. And I think having those choices is really nice for patients to be able to decide what might work best for them. And you're right, you know, some women don't find this painful. Some women find it very painful. And so being able to assess with them, you know, what pain management might work best, I think is really important. The sustainable supply issue, anytime you introduce something new, it's going to be, you know, difficult and challenging, and those systems have to be put into place. But once they are put into place, they're usually pretty easy to continue having the supply available. And then I think the other thing you mentioned is around sterilization or cleaning. You know, it's harder than just cleaning that one little metal instrument, right? But I think the nice thing about the MBA is it can be sterilized and cleaned with almost anything that's available, which is really nice. There are some instruments that only can be cleaned one way, and at least with the MBA, we know that it can be cleaned by hot or cold sterilization systems. And so that gives people flexibility if they're in a low resource setting or if they're in a higher resource setting. And then some hospitals may want to introduce something like electric vacuum aspiration because it's a machine, they have electricity, they don't need to have the MBA, and the technique is similar and the safety is similar. It's just using different equipment for it. So, but I'm sure Dr. Seno has some comments too as well.
Yes. Hey, Dr. Seno.
Yeah.
Yeah.
I think we both agree of MVA has several advantages, that this is faster, cheaper, and it has lower risk complications. But I think I worked in a big hospital, so it seems that this is pain management is very important for the patients, especially for educated patients and have experience with the another services without pain. So it seems that we have some choices to add some choices for anesthesia. So it is very important. I agree for MVA because it's easier for me. Sometimes we just only put it cannula and put it out the remnant of, but it's for the pain. So it seems that the patients, we know that the patients still alert when we insert the blade or give a partial fecal block. So it seems that this patients feel discomfort. And my opinion, this is one of the problem that maybe we cannot do this for this is for this the people like special part of people who need that services. And maybe it's possible that we can add we can do MVA with anesthesia, general anesthesia. So I think it's possible. We know that anesthesia is not so dangerous in recent times. It's not so dangerous in recent time because we have a lot of equipment to evaluate this client. So it seems that we can add the general anesthesia to in MVA procedural if it's possible. But it seems that we have to maybe before general anesthesia, I agree with Prof. Allison to just give like another medical treatment, so pain treatment for our patients and reducing feel discomfort. And I think I agree with that. Thank you.
Okay. This is always both of you have already present about between the. All of you mentioned about the advantage of manual vacuum aspiration, but as in your reality, the fact is, even though in Indonesia it has already developed likely the management of post-abortion care, and then they also promoted and also trained about the manual vacuum aspiration, and this procedure has also introduced in the basic emergency obstetric care. But until right now, it's never been practiced in the primary health care with the BMOC facility. So both of you, do you see, is there any difficulty, how that hard that we can implement this new technology? Okay.
Yeah, that's a great question. I mean, we've had very high success with the type of trainings that we've done, and we found that providers, non-doctor providers, so nurses or midwives or other cadres of providers are very good at following protocols and actually can safely provide for uncomplicated patients this procedure. Obviously, there are other indications or certain patient scenarios that should be referred for, just like for EMOC, there are some patients to be cared for by mid-level providers and some patients that need to be referred. But the really nice thing is the number of women that experience the need for post-abortion care really needs to be, we need more providers to be able to provide that care, just like we need more providers to provide obstetrical care. So in certain situations where training can happen, we actually have very good global evidence that mid-level providers are just as safe as doctors in providing that care. And so we've already had established research both around the globe and also in Asia that this is something that can be done safely with training and mentoring, and then ensuring competency and proficiency. So all of those steps that make a successful training and introduction of services can be done with mid-level providers just as well as with doctors. And that's a very nice thing about this technique, is that it can be used safely by different cadres of providers.
Yeah. Okay, Dr. Seno. Do you have any strategies? Likely we have so many obstacles, maybe in the advocacy or something like that we have an overburden working, or how likely step by step to implement it. It's likely Prof. Allison has already mentioned about the cycle, about the access, reuse, and replace. It's likely kindly, even though there is a new technology, either it's not really a new technology, but how that we can change with the less procedure and we change to the new techniques in this case.
Okay, I think it's very important, and we have to give the information about the whole of the MVA advantage. And then we have to train social provider like not OBGYN, but midwives or nurse or other health providers. And I think this is a difficulty of implement this MVA programs. So some of this is, I think MVA cannot difficult to find in the market. So even in Indonesia, it's not included in the catalog. So even though it's recommended by FIGO and WHO, but you still have difficult find in the markets of the equipment. So I think we need this more is medical equipment suppliers should provide in the market, or government, I think, is to provide this equipment. So first, the health provider, second, the equipment, then third is the programs or the government programs. So I think that's my opinion. Thank you.
Okay. Both of you, I guess in your presentation that you never present about the contraceptive care, post-abortion care. There is a good question from the audience. How about the advantage and disadvantage of between the curatives, and then the manual vacuum aspiration if we want to insert the IUD insertion in the post-abortion care?
Yeah, that's a great question. You know, over the last 10 years, the use of IUDs has increased. But globally, the use of sharp curettage has decreased with the recommendation from the World Health Organization. So I haven't seen any data regarding the differences between expulsion and IUD insertion after MBA versus DNC. One of the things that I would worry about, because you have slightly higher rates of hemorrhage with DNC than with MBA, is that you may not be able to place your IUD, because one of the contraindications is if you have hemorrhage post procedure that you wouldn't put your IUD in. So it may prevent some women from getting an IUD with using the sharp curettage and then placing the IUD. Dr. Sena, do you have any experience with this?
Yes, I think we can insert the IUD, both of the curettage and MVA, especially for the simple case without any other complications. So it's just that if we insert in a curettage has possibility of maybe increasing of infection, because we know that this colitis make a more I think it's more wound inside the uterus. But both of the procedure we can insert the intrauterine, because according to the procedure that we know, that we can do this for both of the procedure. It's my opinion. Thank you.
Okay. Is there how about this one? Sometimes that during we did a procedure of carotid, maybe there is a problem with some, like not all of contraception has been pulled off. Do you think we need ultrasound examination during we do sharp carotid on manual vacuum aspiration?
That's a great question. You know, the interesting part is really sharp curettage is not recommended anymore. And it does have a higher rate of retained tissue, sharp curettage versus MBA. It's interesting because in training people to transition from sharp curettage to MBA, they're very worried about knowing that the uterus is empty. So it's a concern, because with the sharp curettage, people get that uterine cry, you know, the feeling, and they hear it, and they really want that experience with the MBA. And you do still get that experience with the MBA. It's just a little bit less. You have to pay more attention. But I think it's very nice, because as the uterus gets smaller with the vacuum, you really feel that as the uterus gets smaller as you empty the tissue. So the important thing about any time you do a procedure is to make sure that you check the products that you remove, and that you know how to do the procedure and you've been trained to do the procedure. And if all of those things occur, then the need to use an ultrasound is not necessary. And so the recommendation is really, it's not necessary to check. And in actuality, doing the procedure in the appropriate way and checking the tissue is actually going to give you a higher rate of completion than doing an ultrasound on everybody. Ultrasounds really should be used as adjuncts and not for routine care. So if there's a concern that there might be something left, or you don't see what you expect to see after you take everything out, then an ultrasound can sometimes be useful, but it's not recommended for every case.
Okay. How about that the pregnancy is more than 13 weeks?
The pregnancy is more than 13 weeks, and using an ultrasound or using MBA?
Literally, we use an MBA and how to make sure that all the conception is already clean up.
Yeah, so the use of an MBA for pregnancies that are over 12 weeks, there's a couple different techniques that need to be done in addition. And so that care really needs to be what we call expanded MBA use. So up to 12 weeks, the traditional cannulas are used. So you have the dilators, you have a 12 millimeter cannula. Over 12 to 13 weeks, you can still use a 12 millimeter cannula, but in actuality, what's really nice is there is actually a 14 millimeter cannula and even a 16 millimeter cannula that, if you get a special adapter, can be used on the end of the MBA. And so you can actually use a vacuum aspiration technique for even up to 14, 15 week pregnancies or sized uteruses. After that, you really have to use specialized techniques to get the pregnancy out. And so the recommendation is, if you haven't been trained in that, that really you think about doing a medical process or an induction. And what's interesting is that we actually introduced after 13-week services in Ethiopia. They didn't have the equipment. And there was a stigma around doing the surgical procedures for the second trimester care. And so we only introduced medical management of those cases. And they've had a very successful history over the last 10 years of only doing medical management, and they have very similar rates of mortality, morbidity from post-abortion care. And they've seen an incredible success with this, with just introducing medical management for the second trimester once things get higher in gestation, because they don't have the right equipment to do expanded care. So really, we would recommend at that point, if you don't have the right equipment, to switch to medical management of those cases, and using the recommendation of the new recommendations from the WHO, which came out in December of 2018 for those regimens. But I don't know if Dr. Senna has anything to add to that as well.
Okay.
Yes, I think I do agree with this, Professor Allison, because we don't need ultrasound routinely in this situation, especially for simple incomplete abortions. So sometimes we get some difficult cases. It's like closing ostiums, splatted ovum, some kind of ectopic pregnancy still inside the uterus, but ectopic pregnancy, or some kind like another problem. So it seems that as probably we need ultrasound. But in my opinion, in the big hospital, I think this the quality of our procedure is very important. We have to know about the cleaning of the uterus after we remove the remnant of pregnancy. So it seems that we need ultrasound, but not all the procedure need ultrasound. If we work in outside the hospital, not in the big hospital, because we know that CMVS, we have a setting for outpatients clinic, in my opinion. So I think we choose that this MVA done in simple incomplete abortions. So it seems we don't need ultrasound. So I agree with that, because we have to make the minimal of cost of the procedural. This is my opinion. Thank you very much.
It's about the time, yeah. Okay, there is actually still one question from the audience before we leave, and then do you think that we need, it's likely when we recognize the level pain thresholds in patient before we doing manual vacuum aspiration? So even though that both of you has already present about that, if we did a manual vacuum aspiration, we don't need any anesthesia or sedation or general anesthesia. What about if the patient feels something likely uncomfortable? Do you think that we need general anesthesia in this case?
Yeah, so I think, the main point about the general anesthesia is, I think it's the same thing with anything we do in medicine. Every time we do something that's 100% of the time, it's probably not the right way when there are choices available. And so it doesn't mean that you can't use it. It just means that there are more opportunities and choice around it, which then help the patient be able to decide what they might want, because they may have different values and preferences in regard to anesthesia. I think the other thing that happens is anytime people are very used to doing cases under general anesthesia, the way that you handle patients and handle the procedure are slightly different. And we see this in my setting in training. So if we have trainees that are only doing cases under general anesthesia, they don't have to talk to the patient. They don't have to tell the patient what's happening. We don't need somebody holding the patient's hand, helping the patient talk through the procedure, being the advocate for them. But when a patient's awake, you have to be very gentle. You have to be efficient. You have to know what you're doing every step of the way so that you can do it safely but efficiently. And then you have to have somebody supporting the patient and really talking them through, distracting them, doing, what we call, Verbicaine or talking to them. That doesn't mean that they shouldn't get pain medication, but it's a different technique and it's a different style that people have to get used to and have to train in, because if everybody's asleep, you don't have to do that. So it's a different way of helping the patient through the process. But if somebody wants general anesthesia, they can have general anesthesia. It doesn't mean that they can't. It just means that they shouldn't. Not everybody should get general anesthesia.
Yeah, Dr. Seno, before is there any comment?
Yes, I think as MVA techniques has been recommended by Vigo and WHO, it is superior techniques. But honestly, I thought I suggest that maybe we have two options: at paracervical block and option of add anesthesia with general anesthesia is possible, and this is more comfortable, and such as with some of the part of our people, so need that is comfortable. So I think this is a very important point for NVA procedure. This is my opinion.
Okay. Actually, there is an interesting question. One more. It's for Prof. Ellison. You know the incident of IUD expulsion if we use manual vacuum aspiration is more higher the incident of IUD expulsion or lower than using sharp curatives?
Yeah, it's a good question. I have never seen the data around it. So, and now that we're not really recommended to do sharp curettage, I'm not sure that we will see that. So, although it's an interesting question to ask, the more important question is just, going forward, is it okay to put an IUD in after you do a manual vacuum aspiration, which it is. So it safely can be done after an MBA. And the expulsion rate, expulsion rates are slightly higher after post-abortion care versus interval placement, but it's still possible.
Thank you, Prof. Ellison and Dr. Seno Aji. Our debate session, and we already know about all the evidence of the manual vacuum aspiration, and then we recognize how the challenges that we can implement or that we use is in our daily practice in the not just really at the level A in the referral hospital, but particularly that maybe we can also promote this training in the on the public health service, particularly in the primary healthcare. And then slightly our second challenge is in here how the insurance sustainability supply is likely a big homework for it's a big homework for particularly in our society, that's Indonesian Society of Obstetric and Gynecology, and already guideline. And we also participate that we do an extensive training, but I guess that Prof. Ellison is already stated about that. It's need a sustainable advocacy to the Ministry of Health, how that we can implement and use the manual vacuum aspiration. Okay, for this debate session today, and we would like to our gratitude. Thank you so much, Prof. Ellison, and then also Dr. Seno Aji. Hope this could be make a better our health service to be productive. Thank you.
Thank you. Bye-bye, Prof. Thank you, Prof. Ellison.
Thank you so much.
We will give the time for the committee.
Okay. Thank you, Prof. Ellison and Dr. Seno for the informative and insightful presentation, and Dr. Ratna, who helped lead the sessions. We are kindly thankful for every doctors and seniors who have participated in this session. Untuk sesi selanjutnya ialah coffee break sampai dengan pukul 15.40, dilanjutkan dengan keynote lecture. Untuk mengakses ruangan tersebut, peserta dapat mengklik link yang ada pada kolom komentar di aplikasi atau website DocWitty. Dengan demikian, saya sebagai MC mohon izin undur diri. Mohon maaf apabila ada kesalahan dan kekurangan. Sampai bertemu di sesi selanjutnya esok hari. Terima kasih atas perhatiannya. Wassalamualaikum warahmatullahi wabarakatuh.